Madam Chair, we're live.
Great, thank you. Welcome to everybody. Welcome to the members of the committee and people who are watching to the Joint Labor, Health, and Social Services Committee of the Wyoming Legislature. We are meeting online again. This is our last meeting of the interim, and hopefully we can take care of our business, maybe even today if we're feeling prompt. LSO, would you call the roll, please?
Senator Baldwin.
Here.
Senator Bouchard.
Here.
Senator Pappas.
Here.
Senator Schuler.
Here.
Representative Barlow.
Excused.
Representative Clem.
Excused.
Representative Dayton Selman.
Here.
Representative Hallinan.
Here. Here.
Representative Roscoe.
Here.
Representative Stivar.
Present.
Representative Sweeney.
Here.
Representative Yin.
Here.
Co-Chairman Senator Scott.
Here.
Co-Chairman Representative Wilson.
Here.
We have a quorum.
Very good. All right, LSO, is there any business before I call upon the Department of Health for their reports update?
No, ma'am.
Okay, well then let's, committee, we had there, if you recall in the last session, House Bill 2 was a reporting bill. Rather than put requests for reports in the budget as budget footnotes, it was decided that it would be better to have them all actually in a separate bill. So there were a number of reports that were assigned to be reported to us often by October 1st, but Chairman Scott and I decided that because last meeting was so full, we would just put off the ones that were really more reports to today. So that will be the first item that we will hear. And then after that, we will follow up on the 2019 bill on abortion reporting. So good morning, Department of Health. I see Mr. Fuchs and a few other folks. Why don't you give us a report? And I believe we've got that is in the packet. Let's see, page 4. Or so there.
Good morning. Good morning, Madam Chairman. Good morning,
Good
members of
morning.
the committee. Can you hear me okay?
We can hear you.
Excellent. Again, members of the committee, my name is Franz Fuchs. I'm a policy analyst with the Department of Health. And if it's okay, I'll share my screen here. Maybe it looks like it's disabled, but I have a presentation, some slide deck to share.
LSO, can you help him?
Yes, that should be enabled now, ma'am.
Okay.
All righty, let's see if I can find this. Okay. Can you see the screen okay?
We can.
Excellent. So again, Madam Chairman, we have 3 reports to present to you today, just the summaries. The first will be on the community choices waiver. The second will be on the abortion reporting. And then the third will be by the Behavioral Health Division on the early intervention and education program. So just beginning with the community choices waiver report. This report was required to the JAC and Joint Labor as part of House Bill 2. And essentially the bottom line is asking whether or not the waiver is cost effective compared to institutional placements. So just to cut to the chase, our estimate is that uncapping enrollment in that waiver in 2013 has almost certainly avoided cost growth in the Medicaid long-term care component. Now, while the exact amount is difficult to pin down, we tried to bracket it. So we use a low, sort of a very conservative estimate of savings and a more generous estimate of savings. And that cumulative savings over those fiscal years, those 5 fiscal years, is somewhere between 0 and 66 million. So you'll note that the 0 is sort of that lower bound, and that basically means that there were no, we don't believe it's possible that there were additional costs. And so our best guess is kind of at the lower end of this range, probably to $10 to $20 million over those 5 fiscal years. But at the end of the day, the worst case, even if it was 0, which is sort of our lower bound there, Medicaid would be serving more people with the same amount of dollars. So at the end of the day, Medicaid and the Department of Health strongly recommend that we maintain the emphasis on home and community-based alternatives to nursing homes and other institutional placements. So that's our bottom line. The report itself kind of has some more detail in there about, for example, this is a kind of an eye chart graph, but this combines some of the figures on page 3 and 4. I'm sorry, page 3 of the report and page 5 of the report. And so just to walk you through real quick, we have this talk about this sort of the silver tsunami effect that's happening or it's projected to happen. We wanted to give you a little more detail on kind of how it looked by county. So each of these small little graphs shows each county in the state. The dashed black line is the state average. So looking at the y-axis is the percent of population over 65 years old. And so we're kind of seeing how that's going to grow as a fraction of the population over the x-axis, which are the years ranging from 1990 to 2040. So a very kind of wide time scale here with the dashed vertical line kind of showing where we are today. And so it's interesting to see what kind of by county, how these projections work out. Certain counties are pretty much like Carbon County, reflective of the state average. But then you have counties that are generally older than average and will stay that way, like Hot Springs and Johnson. But then we also have counties like Sublet, which are actually going to be rapidly changing. So you can see that Sublet was fairly average, but just recently starting to increase pretty dramatically and will be one of the older counties in 2030, 2040. So just sort of some interesting background information there. When we look at on the right side of this slide, we see the Medicaid long-term care enrollment graph. And so this is sort of 3 subgraphs. The top one shows a kind of a stacked bar graph. So you can see as a cumulative, the top line there is the total long-term care enrollment, but it's divided into blue, which is the community choices waiver, and brown, which is nursing home, and then sort of dark gray, which is PACE, which is that unique program that's only available in Laramie County and serves about 130 folks. The dashed line represents kind of when the waivers were uncapped. So you can kind of see the effect of what happened with the waivers over time. As sort of, we've seen long-term care enrollment increase, but that increase has really been in that waiver component, whereas nursing home enrollment has actually fallen in particularly the last couple of years. When you look at that individually, which is the middle graph here, so now we're not looking at kind of stacked, but you can see the trend lines for each of those programs in the middle graph. And then the final graph here just kind of shows the percent of home and community-based services. So looking at PACE and looking at the community choices waiver out of the total, ever since the waiver was uncapped in sort of the summer of 2013, you can see the steady growth that we've seen in the percent of people being served in home and community-based settings. So we're over 60% now, which is excellent.
Franz, just an interruption here. Could you reduce the zoom on your document just a little bit, because the edges are being hidden?
Reduce the zoom. Okay, Madam Chairman, I'll try to figure out how I can do this on the.
If it's at 100% now, can you put it like at 90 or something? Because I think we're not getting the edges of everything.
Okay, I will.
Are you able to do that? Just
So
in your PowerPoint or whatever it is.
Right,
Maybe.
I'm adjusting the zoom here, but on the browser, but it's not doing anything.
What about in the actual document you're showing?
Moving around. Yeah, I'll try to.
Well,
maybe I can. That just
although
shows the.
now
yeah,
it's really
unfortunately,
tiny.
The presenting mode just kind of shows the entire deal.
Well, okay.
Let's see if I can maybe. Yeah, that's not helpful. So there's a fit, but again, I think the aspect ratio of my computer here, this laptop, is not helpful. So I apologize for that, Madam Chair.
All right. Well, if we have questions, we will ask. Go ahead. Go back to the way it was. I think bigger is better, probably. All
righty. And again, you can refer to the report. These are on the figures on the report itself. So I've just sort of combined them onto one awkward and consolidated slide. Okay. If that makes sense. So that was, again, figure 1 and figure 2 on the report. The other interesting trends we looked at in this report are on this slide, which is figure 3. And this, again, kind of a little bit confusing on first glance. But I think it's pretty helpful to kind of understand what's happening with Medicaid. What we did was look at the rate of home and community-based enrollment per 100 people in the actual the census estimate. So we're looking at sort of Medicaid enrollment as a fraction of the total population, not just Medicaid members. And we have four sort of graphs here. These represent the top two represent the community choices waiver. So we have male. This is by male and or sex and age. So male on the left, female on the right. And you can kind of, and these multiple lines here show years. So each, the dark purple, it starts in, I believe, 2010, and the yellow represents 2019. So this is basically almost a decade of experience looking at enrollment as a function of population, as a fraction of population, kind of the rate of enrollment per person or per 100 people here. And what's interesting is you see two interesting facts here. The top is the community choices waiver, as I mentioned. The bottom is nursing home. So you can see the nursing home, just the shape of these lines here. The community choices waiver is serving kind of a more even demographic. So if you look at the age from 45 to 85, there's a lot more folks with physical disabilities being served in the community. And that fraction has kind of grown. So you see that this line overall is generally kind of moving up. You know, the rate of Medicaid enrollment per 100 people has generally increased over the same time period over a relatively even kind of over a function of age, right? So it's relatively even. This slope is kind of increasing pretty steadily. Where if you look at nursing home, the nursing home has tended in the past to serve much older folks. So you see that it's a much more sort of a sharp curve, exponential kind of growth as you get past age 65. The risk kind of nursing home enrollment, as it were, kind of increases pretty dramatically after that age. But what's also interesting is you can see the rate of nursing home enrollment has also shrunk somewhat. So not as much, males is a little bit relatively similar, but for females, we've seen this sort of decrease from the purple lines to the yellow lines for older Wyomingites being served in nursing homes. So just some interesting trends from just looking at sort of a risk perspective of nursing home versus Medicaid long-term care enrollment on that graph. And I know this is kind of a confusing graph at first glance, so hopefully, but I'm happy to take any questions or try to understand, explain what's going on here.
Questions for
wasn't
Mr.
clear.
Fuchs? And if you have some, speak up, because I can only, what with this slide showing, I can only see a few of you. Let's see. No questions? Okay, go ahead.
Okay. So again, once we kind of got this background information, we kind of proceeded to sort of our estimates of cost savings. And what we did is, the real tricky part here is estimating what would have been had we not uncapped the waiver. So it's sort of this what's called a counterfactual. It's we need to kind of know what would have happened to nursing home enrollment if the waiver had remained capped. And what we did is we sort of had these two sort of upper bound and lower bound. We're attempting to bracket it using these various assumptions. So the upper bound, the very generous assumption, is that every new member on the waiver directly avoided a nursing home placement. So that's pretty straightforward to calculate. You just look at the enrollment. You assume everyone, all the new enrollment after the waiver was uncapped would have been in a nursing home otherwise, and you basically take the per member per month difference between those two settings and multiply that out. And you'll see that on tables 2 and 3. Those are the per member per month differences. And then our upper bound calculation is table 4 on page 9 of the report. So you can kind of see the avoided nursing home member months under this assumption, the relative difference in the per member per month cost. And you can see the avoided cost is sort of a cumulative amount that's been increasing. And we're estimating, if you add all that up from 2014 to 2019, those 6 years, that's $66 million in avoided cost in that under those assumptions. Now, the lower bound scenario is much more conservative. And we basically, here, we just look at the rate of nursing home enrollment by age and sex group at a 2010 to 2013, and we just assume that it remained constant. So that rate did not change, did not go up, did not go down. And that's, I think, a conservative assumption because, when we looked at our previous aging report, we were pointing out that, not only are we getting older as a society, but we're also getting sicker. There's more, people with increasing number of chronic conditions. And so it's more than likely that nursing home enrollment, had we not uncapped the waiver, would have increased as a rate, as a function of the population, just due to that sort of fact. However, this sort of estimate's a lower bound, and again, conservative, because we're assuming that didn't change. It just remained the same. So when we look at that assumption, we have, again, another eye chart here, and I'll just start taking it from the top left. The annual nursing home enrollment, the actual enrollment is represented as the black line here. And then we have the waiver being uncapped in 2013 with the red dashed line. And then their counterfactual estimate of the rate being the same from 2010 to 2013. That is just based on population growth, and the underlying demographics is what the nursing home population we estimate would have been under these assumptions. And so the difference is that the gap between the dashed orange line or brown line and the black line is the sort of avoided enrollment that the enrollment that we've avoided in nursing homes since the waiver was uncapped under this conservative scenario. And then under the HCBS on the right, we see the actual enrollment is the black line again, and the counterfactual of it being capped, we just keep it the same, right? So we have additional HCBS enrollment, sort of the difference between the dashed blue line and the black line there. And so when you take the cost of that voided of the additional additional HCBS enrollment, of that addition, so that's sort of over baseline, right? And we subtract out the cost savings from the avoided nursing home enrollment, we get the graph on the bottom left, which kind of shows, net cost versus savings. So it's basically over this period of time, it sort of fluctuates, but it ends up being kind of a wash. That dashed black line is the cumulative sum of those, the individual sort of inner gray bars, which represent the net costs or savings, with the blue and the gray kind of being the nursing home and the HCBS cost or savings respectively. So under the left, if you're just considering Medicaid, state general funds, and federal funds, under this scenario, it's a wash. But we basically end up a little bit on the saving side, or a little bit on the cost side, but basically it's close enough that it's a negligible fraction of a percent kind of that total expenditures. Now on the right, we include the upper payment limit injections. So basically there's, as you all know, there's sort of this program or quasi program that enables us to draw down additional federal funds with using provider funds as sort of the match, the state component of that match. And that goes up to the Medicare rate. And nursing homes and hospitals are some of the bigger beneficiaries of that. So when we include the upper payment limit, additional federal funds in that, you can see the costs. We actually do see savings when you consider all dollars, not just state funds and regional Medicaid funds. So under this scenario, this is kind of how we arrive at our sort of zero cost, net cost estimate under the conservative assumption. So at the end of the day, that's kind of what we use to bracket it. I don't have any more slides for you, but with those two kind of bracket estimates, it's more than likely it's closer to that lower bound, that more conservative estimate, but that still leaves us kind of with genuine cost avoidance being the most probable kind of scenario here. So at the end of the day, we do, because of this evidence, we really, and because obviously people prefer being served in home and community-based settings, we strongly recommend that the state continue to pursue the policy of really incentivizing care in those home and community-based settings. And with that, I'm happy to take any questions on this.
Questions for Mr. Fuchs?
Madam Chairman.
Co-Chairman Scott.
Madam Chairman, question on, and relates to the computation here. For a while, the life expectancy was increasing, and the amount of disability at any given age was going down. Is that, and I haven't seen those figures for about 10 years now, is that trend continuing, and does that affect the calculations?
Mr. Fuchs.
So, Madam Chairman, Mr. Co-Chair, We did not explicitly include that in the calculations here. We assumed that basically everything else was equal, and this is really over the time horizon of a decade. So it really, my guess would be that disability and life expectancy have not changed that dramatically over that period of time in Wyoming. However, we could certainly try to look at it. I doubt that the Wyoming specific data is really available to kind of get that kind of calculation, the detailed calculation. All we're assuming is that we have seen evidence nationally that aging populations are increasingly burdened with chronic disease, and that comes from national surveys. So based on that kind of assumption, that's why we think the lower end projection is a conservative one, and why we think our best guess is a little bit higher than that. But we did not explicitly include that in the math, if that makes sense.
Madam Chairman,
Co-Chairman Scott.
That's one of the things I'm wondering about, because for a while, the amount of disability was going down at any given age group, and has that trend, do you know, has that persisted? I'm questioning the assumption that the amount of disability is going up. Now, it may have started going up. We've had the obesity epidemic. We've had problems with opioids and drug abuse. We've had some other things that have would tend to increase disability, and so I don't know whether the trend of the amount of disability going down is even continuing.
As we used to say when I was a psych major writing papers, more research needs to be done. Okay, any more questions for Mr. Fuchs? What I'm going to do, because I on my list of people who want to comment on the reports, I think there is one commenter on this, and I'm going to take the different comments on the different reports just so as to not kind of confuse things with comments on a variety of reports later. So Ella, so I think Mr. Scott was in. If there are anybody else that's specifically wanting to report or comment on this report, and I know you may not have been able to discern that, but I think I may hypothesize that Ramsey Scott probably wanted to comment on this one. So if he's there, let him in and we'll hear.
Madam Chairman, Ramsey Scott did let us know via email that he would be unable to comment this morning.
Oh, okay then we will not. Franz, when you stated that you had the reports, you said there's this one and then the abortion one and then the preschool waiver. Because we listed the abortion reporting separately and that was not from the bill, let's do go ahead to the preschool issue next, and then we'll come back to the abortion reporting.
Yes, Madam Chairman. We do have some folks from the Behavioral Health Division that would present that particular report. And I'm not sure if, so I'd request LSO, if they're not already in here, to allow Aaron Doak or Matt Petrie or Heather Babbitt into the meeting room so they can present on, and I can drive the slides. But they have all the details for any questions you may have.
I think Heather's in. I saw Matt Petrie for a while there, I think.
Yes, ma'am, we're here.
Okay. If we can go ahead with that report, that would be super. And I think we've got some commenters on that one too. So. Oh, wait, I'm going to stop you for a moment. Take your screen off there for a moment so that we can see the people again. I just was recalled one thing, which is that while we have everybody here, because I know people seem to move off screen and go away and come back, I just did want to thank Representative Clem and Representative Dayton Selman for their longtime service in the legislature. They're both retiring this year. Representative Clem has been my able vice chair for 2 years, and Representative Dayton Selman, we've served together on labor and revenue both for many years, and we will miss them both. I'm sure they will have not lost the way to the Capitol or the Zoom meetings, so no doubt we will hear from them again. If we were all in person, you know, we would have cake and punch and dinner and all sorts of wonderful fun things, but thank you so much. We'll miss you, and best of luck as you go forward. Okay, now we'll hear from Department of Health.
All right, good morning.
Good morning.
Thank you, Madam Chairman. My name is Heather Babbitt. I'm the Deputy of the Behavioral Health Division. We're here to talk today about developmental preschool funding and our legislative report. Here with me today is Matt Petrie, our Division Senior Administrator, Kathy Escobedo, who is our Early Intervention and Education Program Unit Manager, and Aaron Doak with our Operations and Policy section. And we have a few slides to share with you today. Go ahead, Franz.
While you're lining
Madam
that up,
Chairman.
oh, go ahead.
Sorry, Madam Chairman, I was hoping to, I was trying to share it. Hopefully that's visible now.
We see the first one,
We see it,
Okay.
Franz.
page 13.
Okay,
It's
great.
there.
Just proceed to the next slide. Got it.
Okay, yes, please, sir. All right.
And Heather, just before you, to give us a little background on this, I do not recall, and maybe Chairman Scott knows else otherwise, but I somewhat think that it may have been appropriations that put this request into that reporting bill. I know that from my time on appropriations that this was often an issue. Do you recall, Ms. Babbitt, what the origin of this particular requirement was?
Madam Chairman, yes, I believe that you're correct. It came through joint appropriations with the directive to provide the report to them as well as Labor Health.
Okay, and I assume you will be doing that during the Department of Health's presentation, agency presentation or something?
If requested, absolutely, Madam Chairman.
If requested. Whether the JAC will request it or not, committee members, it's on us then to at least retain this information and poke your neighboring JAC member as required. Okay, go ahead, Heather. Sorry about that.
No, very good. Thank you, Madam Chairman. We were asked to provide a report on the following items: the adequacy of funding, the method that we request our fiscal year appropriations, how we calculate payments to our providers, and then provide any other recommendations. And as we go forward with these few slides, I do want to point out that we do provide early intervention and education program funding by contracting with 14 child development centers around the state. All right, next slide, Franz, please. All right, on this slide here, we're talking about adequacy of funding. And to determine this, we enlisted the help of our existing data contractor, who is data-driven, to help provide the data that you see in the report. And you should have a very detailed report to reference back to. To gather this data, we had 100% of our child development centers and 90% of the school districts did respond to a survey that we completed in the spring. For the purposes of this report, adequacy is based on information shared in past reports regarding provider compensation, as well as looking at child development center expenditures and reviewing the per child funding model. This is the first year the program has collected CDC expenditure data. And while we assume the data is correct, we have not validated it. In addition, the method of calculating expenditures for the child development centers is different than the method used by school districts. The child development centers also carry the burden of maintaining their buildings, providing transportation, et cetera, vehicle expenses, that kind of thing. And we're not sure how this works in the school district in terms of calculating expenditures, but those kinds of expenditures are included in the child development center data that you are looking at. The detailed compensation and expenditure data you can find in the report, but in summary, as we've said here on the slide, the CDCs lag behind in both salaries and per child expenditures. And we would like to point out, as you look at this data, that there are obvious differences between the length of the preschool day and the length of a K-12 day. And so students in K-12 typically are attending for a full day, which is about 32 hours a week, while students at the Child Development Center in preschool services would range from 10 to 12 hours per week. So the duration and frequency of special education and related services provided to students in the K-12 setting far exceeds that in the Child Development Centers. Next slide. Okay. All right, this slide we're talking about how we calculate provider funding. What we do when we look at funding, we provide, we make sure that we are in compliance with our maintenance of effort. And we have a maintenance of effort requirement for Part B as well as for Part C. And for those of you maybe unfamiliar with the Part B/619, what that refers to is federal Part B funding is the funding that is provided to students with disabilities from age 3 through age 21. And our program is the small slice of 3 to 5-year-old kids. And that's what we call Part B/619. So we refer to it both as Part B and Part B/619, but that's what that means. So the first thing we do every year is ensure that we are in compliance with our maintenance of effort. And to do that, back in 2017, there was a lot of conversation about this, as you'll remember, and we worked with us, as some of you will remember, and we worked with the Department of Education to receive some training and technical assistance to ensure that we calculate and track our maintenance of effort correctly. And so we left that training opportunity with a maintenance of effort calculator, and we continue to use that calculator to ensure compliance for Part B maintenance of effort. To ensure compliance for Part C maintenance of effort, at that same time, we worked with Mr. Fuchs and Ms. Escobedo worked to create a maintenance of effort calculator for Part C. So we have a formal process to track and monitor our maintenance of effort for both programs. So that's the first thing we do. The second thing we do is we look at the annual child count, which is conducted on December 1st of each year. And we use this number to set the budget and set the contracts for our 14 regional child development centers. And each provider receives an annual contract equal to the number of children on the count multiplied by the funded per child amount. So that is how we determine calculations. And on the next slide, I'll explain this in a little bit more detail. We can go ahead. Okay, so in order to determine provider funding, what we do is part of that is every year we are directed to prepare a supplemental budget annually. And we have 2 requests as part of that budget for EIEP. And one of them is looking at the per child funding amount. So Wyoming statute 212706 prescribes the base child amount that we use when we start to calculate funding. And that base child amount is $8,866. We are then further directed to add any external cost adjustment that we might receive from the Department of Education to that per child amount. And then we calculate the new child amount going forward for that year. In addition, we make our best estimate because the supplemental budget is prepared prior to December 1. It's prepared in late summer, early fall. We make our best guess as to what we think is going to happen with the annual child count. And we think about, what we think the increase might be. And it really is a best guess kind of thing. But we do that to put a placeholder in so that we can go in and ask for funding for those additional children. Once we complete the count, then we usually in the December budget hearing process, we adjust that supplemental request. For example, last year there was no increase in the account, so we withdrew that request. So that is what we do to determine funding calculations. And then once the legislature has completed and we know what our budget is, we make those 2 requests. Sometimes they're funded, sometimes they're not, sometimes they're partially funded. We take that final budget amount, we divide it by the child count for each provider, and we execute contracts for the coming state fiscal year. And that is how we determine provider funding calculations. The last part of the report, which I don't think we have a slide on, was additional recommendations. And you can see in the report that there are recommendations specific to collecting data, funding the program, and providing services in collaboration with the local school districts. And we agree with those recommendations, and those are things that we do look at regularly and work on in the program. However, currently in the program, given the budget reductions that we've recently had to implement, we haven't really fully seen what those impacts are. So it's challenging for us to talk about funding adequacy in this kind of environment. That being said, we are working very closely with our providers to ensure that services continue to the kids in the program. And we do have an obligation for all kids on a family service plan or individualized education plan to ensure that they continue to receive the appropriate services. So we do value the recommendations in this report and are working towards those recommendations, but right now really working with our providers to ensure that we continue to provide services to kids. And with that, we are done and would stand for questions.
Madam Chair.
Sorry, questions for Ms. Bobbitt. I'm sorry, I'm trying to manage all these screens and things. You will perhaps be interested to know I'm a member of the subcommittee, or whatever we're called, on legislative facilities, technology, and process. And evidently, we are perhaps going to all be getting an extra monitor for our desks so that you can have the documents up and look at people's little rectangular faces. Chairman Scott.
Yeah, Madam Chairman, I got a couple questions on this. One of the measures of adequacy here needs to be how much we're saving the special ed costs in the K-12 system, because it is, as we saw, a good deal cheaper, and I have a question on that, a good deal cheaper to treat a kid in the child development center and the earlier age. It's for a number of reasons. And I was on management audit when we looked into it, and then they had some inconclusive results and we had to look further. And when you compare us with other states, we are saving significant amounts in the special ed costs by funding the child development centers. Is there anything in the report on that particular aspect of the financial situation? In other words, if we spend more money on child development centers, are we going to save more than that in special ed costs? And there's a timing factor in there too. So,
Ms. Babbitt.
Madam Chairman and Co-Chairman Scott, the report does not go necessarily into that detail. I can tell you that for Part C, to your point, we have 22% of kids. So our Part C kids are the birth to 3 exit the program not needing additional services. So it is impacting in a positive way kids' progress.
Chairman Scott, I remember from, I don't know, 6 or 7 years ago, there was a discussion at a joint meeting of education and labor about just the challenges of this program being in Department of Health with general funds, I assume it is, and the special ed services and education, whatnot, coming through school foundation program. You know, I mean, it's one of those challenges that we see in the healthcare system where, because it's not all one system, when you save money in place A, it's not really, it doesn't really incentivize some other location differently funded. I don't know if you recall that discussion.
yeah,
Scott.
I can remember that discussion. And frankly, from our point of view as legislators, we ought to treat it as all the same funds, because we're going to have to supplement the school funds with general funds anyhow. So if we can save money by spending more general fund here, if we save school foundation money, that would be a lesser hit in the general fund from the school foundation program. So from the legislative point of view, so what about the funding source? It's all coming out of this, the marginal dollars are all coming out of the same pocket. The when you do, we run a much higher enrollment, Madam Chairman, in the child development centers than programs in comparable states, and it does show up in the special ed expenditures. We did get it somewhat documented. It's hard to get things that are comparable because things are organized so differently. And I would say that one of the reasons that this is in health department is considerable fear, which I think is valid on the part of a number of us in the legislature, that the educators would impose a very standard classroom model on this that would not be age appropriate for these younger kids, and the medical model works better. And nothing to do with funding sources. It has to do with the way that various institutions naturally approach this population. The question I've got for the department at this point is, the figures are showing it's a good deal cheaper to serve the kids in the preschool setting. And is that related to the fact that for many of these disabilities, maybe all of them, it's easier to treat, you have better results the younger you treat them. So if it's easier to treat them, then it may be cheaper to treat them then. Is that what's going on? Or the other potential is that the business model that the educators are using is just naturally more expensive. The kids are there more of the time. They're paying a higher wage. There's a number of things that may be influenced by the fact that we have reimbursed special ed in the school districts at 100%, and that could obviously drive the costs up. Do we have any information on what's causing that big differential in the cost?
Ms. Babbitt?
Madam Chairman and Co-Chairman Scott, I think, we would side with the latter of what you said. It is more expensive. They're in the school longer. They get those longer time in school, but we don't have a lot of information on that.
More questions for Ms. Babbitt? Representative Sweeney.
Thank you, Madam Chairman. Ms. Babbitt, in these first round of 10% cuts, it appears that the cuts were in general higher to this area. Did it boil down to more than 10% in this first round to child development centers and in this side of things?
Ms. Babbitt?
Madam Chair, Representative Sweeney. I'm Matt Petrie. I'm the Senior Administrator of the Behavioral Health Division, and I'll try to answer that question. As Heather indicated, the program itself is broken into essentially two parts. Part B is the portion of the program that we receive some funding through the Department of Education for. Those are essentially federal pass-through funds. And that portion of the program serves children ages 3 through 5. Part C of the program is optional, so to speak. The state of Wyoming has decided to opt in to that program. And Part C serves children birth through age 2. So when we fund the programs, we actually fund both sides of the program at differing levels. The per child amounts are different between Part B and Part C. What we did in our budget cuts, the first round of budget cuts, if you will, or what's referred to as step 2 of the budget cuts, is that we attempted to avoid any kind of cuts in the contracted amounts to the Part B providers. The Part B of the portion of the program that's federally mandated and is partially funded through the Department of Education. So what we did was we cut the Part C portion of the program, and the reduction in that in its entirety was 22%. So the amount that was contracted to the Part C providers, that reduction in payments per child was reduced by 22%. On the Part B portion of the program, which is considerably larger, there were no contractual reductions. The amount that's being paid in the current contract cycle is the same as it was in the previous contract cycle. So in short, we did see more than a 10% cut to the Part C portion of the program and those contracts to those 14 CDCs. But on the Part B portion of the program, there was no cut to the contractual amounts. When you look at the program overall, you combine both Part B and Part C, the grand total of cuts to the programs as a whole came in at 10.2%.
So Matt, following then on that, how does the number of enrollees in C compared to B? I mean, have we had, are they essentially the same children for 5 years, and or are they different children?
Madam Chair, I will defer to either Heather or Kathy on that. I can tell you, as Heather indicated earlier, you can see some success in Part C of the program where the children realize that success and there's no need for them to move into Part B. Of course, you can see the same thing in Part B where the children have success in their program and so there's no longer a need once they move into the K-12 system. But in terms of the split between children served in Part B and Part C, again, I'll defer to either Heather or Kathy for that answer.
Well, and so just a kind of a tack on then, Heather, and by no means am I, we all understand the budget challenges, and if we could fund everything that we think is great and is doing something well, we would need a lot more money than we have. We totally understand that. But so if we are funding, essentially a quarter cut in Part C, is the thought that these children we'll pick them up when they turn 3 in Part B, and if there might be more children or children that need more services because of not having Part C, will there be more federal dollars then for those children? In other words, is it a sort of a reimbursement type of thing, fee for service thing, or will the dollars in Part B remain constant from the feds regardless of what we do to Part C? That makes sense?
Madam Chairman, yes, ma'am, and you have a lot in there. I'll try to unpack that. So if I miss something, I think I can address the things you've brought up. So if I miss something, redirect me. But last year, or our current state fiscal year, we had on our count 3,645 kids. Of those kids, 1,207 were in the Part C program, and 2,438 were in the Part B program. So we do have different numbers. It's not the same kids. It can be the same kids, but as Mr. Petrie pointed out, kids can transition out of C and not need services. They are assessed to see if they need to continue to receive services for Part B. And so we have kids that transition between programs. And then another big priority of ours is kids transitioning from Part B into kindergarten. And do they need services in kindergarten? And we work a lot with Department of Education and our CDCs with local school districts to ensure that we have that transition down as well. So the annual child count is what has been established to determine the budget for the program for the legislature to consider during the subsequent session, it's not a reflection of the number of children served. So in the year, will exceed that count. So kids will come and go from the program, and the actual number of children served is different than the number of kids on the count. Regarding the federal funds, they come to us for Part B through the Department of Education, as you have briefly touched on, and I don't want to muddy this too much, and they come to us directly from the federal government for Part C, and each, like I talked about, has its own maintenance of effort requirements. So given, and then we contract that, some of those federal dollars also go to the CDCs, and at this point, they still have their same amount of federal funds. So because of how we implemented the reductions, as Mr. Petrie described, we have no impacts to our federal Part B funds at this time. Our Part C funds, we are in conversations with our federal partners about our Part C program. This is really unprecedented times, as you've touched on, and so we're in conversation about that. But as of right now, none of our federal funds for the CDCs have been reduced. You also asked about the funding per child. It's not a funding model where the money follows the child. So again, that child count and that per child amount sets the budget. But if Johnny is on the count on December 1, he doesn't go into the program with a X dollar amount budget. The CDCs use that money, as we talked about and is in the report, for all of their operating expenses in addition to providing services. So the funds don't follow the child. Each child is entitled to the services that are identified on their individual plan. And so that is our focus now and always, even with these reductions, is to ensure that kids get the appropriate services in their plan. So I think I touched, Madam Chairman, on everything you brought up, but.
Senator Pappas.
Yes, thank you, Madam Chair. And I don't know, I apologize if I missed it, but the 22% cut reduction in Part C, can you tell me what the total dollars are we're talking about? And also, how many children are being funded by these dollars?
Ms. Babbitt.
Regarding the number of children, so what's our count? I'll defer to you, Kathy.
1207.
Rising in Part C. The current count, Madam Chairman and Senator Pappas, is 1,207 for Part C kids. The total reduction to the EIEP program was $8.8 million, split between B and C, and then split for a 1-year reduction. So the reduction that we gave to the Part C contracts was, I believe, just over $2.2 million
For the current year.
For the current year, thank you.
Madam Chair, so
Senator Pappas, yeah.
but all the reduction was Part C, right? Not Part B.
Madam Chairman and Senator Pappas, that is correct. So we did reduce the Part B budget, but not the Part B contracts. All the contract reductions were to Part C.
Thank you, Madam.
Okay, any more questions for Ms. Babbitt? Chairman Scott.
Madam Chairman, continuing on some of this further, the developmental disabilities we're talking about here, there's a number of sort of age windows that once you pass them, it's either impossible or more likely much more difficult to correct a deficit. And that's just a function of the way we humans grow and mature. By cutting Part C, we're obviously either going to have less kids, probably by the mechanism of just not going out and screening people as vigorously, or we're going to do a lesser job of treating. What are we building in terms of, are there a bunch of these windows that are closing and we're going to miss them and have an expense that's going to last, essentially follow them through a good part of their school careers? Or are we going to see an increased demand for Part B services? Do we have any sense of what we're doing here?
Ms. Babbitt?
Madam Chairman and Senator Scott, Co-Chairman Scott, you know, I can't honestly address everything that you've brought up. I can tell you that there are federal obligations with the Part C program, like the Part B program, around child find. So we do need to continue to try to identify children who can benefit from services in the Part C program. And so there are a lot of factors at play right now that are making it a struggle to find kids and to provide services in a COVID environment. And then with the budget reductions, but we focus on services to the kids. So our staff are working with the child development centers to provide that technical assistance and support to ensure that the kids that are in the program continue to receive the services that are identified on their individual service plans. So it is a challenging situation like you described, Senator Scott, and we, you know, are working hard to ensure that we meet our obligations to those kids. The larger questions on down the road, you know, I can't really address that.
Madam Chairman,
Chairman Scott?
I would say to the committee, this is one we need to pay real attention to when we get to session. I have a terrible fear here that what we're doing is cutting off our noses to spite our faces and building a big financial problem for the future. What we have been doing, we've been identifying a lot more kids than other states. We don't exceed what the experts think are there, but we've been identifying more kids than other states, and I think it's paid off for us. But we could be getting ourselves in real trouble here. So this is one we need to pay careful attention to come session.
Representative Sweeney, I think I saw your hand going up earlier.
Thank you, Madam Chairman. And I appreciate the good work of the Department of Health and on this. I would just ask, as we're going through this, as Chairman Scott just mentioned, I too am very concerned that we're heading down a really bad path, and it's, you know, 4, 5, 6 years from now, this is going to be a really bad situation on trying to shift gears. And of course, these are the littlest voices that have no voice. I am hoping Heather and Matt and the staff are advocating for those little voices that again have no voice. I guess my question is, if Part C, we see additional cuts, will that be, in your opinions, the elimination of our child development centers? In your opinion, do you have any thoughts on that?
Ms. Babbitt, handle it as you can handle it best.
Co-chairman, or Madam Co-chair, and Representative Sweeney, that's a very tough question. You know, when we looked at the budget cuts for the Department of Health as a whole, this program is one of the top 5, absolutely. 90% of our general fund in the Department of Health falls in 5 programs, and this is certainly one of those 5. In terms of scope, it's roughly equivalent to 3 other programs in the Department of Health. So without pushing further cuts, primarily to Medicaid, which obviously is the largest of our appropriations, we did have to make some cuts in this program. We chose to make those cuts, at least in terms of affecting the programs, the child development centers. We chose to make those on the Part C side of the program. Again, because it is not something that is federally mandated through the Department of Education. So there's a little bit higher bar there, I think, in terms of expectations from the federal government and from the Department of Education, with B taking priority over C. So what we attempted to do was to take those cuts, but to apply them in Part C. You know, I think that if there were additional cuts to Part C, that, that certainly will impact the operating revenue for those child development centers. Would it cause them to close? I don't know that we're in a position to answer that question. You know, obviously with any kind of an educational program in the state of Wyoming, you've got some that are much larger than others. And that's certainly the case with the child development centers. So I think, you know, other than to say that it would significantly impact their operating revenue, I think that we could all agree that that's factual. Whether it would cause closures or just scaling back of the programs, I think I would probably have to leave it at that.
Senator Pappas.
Thank you, Madam Chair. Back to just to address the question that Senator Scott brought about whether further reductions in Part C would actually put more pressure on Part B. I just want to clarify, in my mind, if someone could clarify, that the two programs are two different. I mean, they're age-related groups, correct? And so I think you said it was from Part C was birth to 2, and then Part B is older children. Can Part B service children younger than 2? If that's the case, then yeah, it might affect Part B, but my understanding, it probably wouldn't affect Part B. It would just be the children in Part C would not get services, or would get less frequent services, or there may be a rationing of the program of some sort by the centers. And frankly, I think Part C, if I'm not mistaken, the services are in the homes of the clients, and so wouldn't affect the brick and mortar, I don't think, of Part B services. So if somebody could just clarify that a little bit for me.
Now I'll turn that over to Ms. Babbitt, and I'll just say what I was thinking there, and they can clarify this, was that if a child who, say, was 18 months old and had some delays, didn't receive any services, then when they turn 3 and are eligible for these services, they might have had some delays or that sort of thing that hadn't been treated, and thus might require a little more work after their 3rd birthday. I mean, that's what I was thinking. Heather, Ms. Babbitt.
Madam Chairman and Senator Pappas, I think that your assumptions are correct. If a child does not get services in that birth to 2 range and they're identified at age 3, they would come to the Part B program, potentially needing additional services. Again, you had a lot in your comment. I can't remember everything you wanted me to address, but I think that your comment, Senator Pappas, about the different options that potentially CDCs would have to look at is correct. It might be a scaling back of services. We're still certainly operating a Part C program, and they are providing services, so I think your options that are all potentials. We don't really know. Each CDC is different. Their financial picture might be different. So.
Okay, Senator Scott.
Madam Chairman, follow up on Representative Sweeney's question. For the health department, has the department anybody in the department looked at the balance sheets and income statements of these programs to see if we have any at risk of having to go out of business?
Ms. Babbitt?
Madam Chairman and Co-Chairman Scott, we do receive the annual fiscal reports from our providers related specific to these reductions. No, we have not specifically looked at that.
Okay, committee, I
Madam
think,
Chairman,
Chairman Scott.
Madam Chairman, let me strongly recommend that you do that. I haven't heard that there was a problem that way, but I do recall this committee found a problem, must have been 5-6 years ago, maybe longer, in the developmental disability things. And when we looked at those, we found they were about to lose 4 of them. And we had a tremendous struggle getting that resolved. These are they're different circumstance, and it may well not be a problem, but I think with this magnitude of a cut, it would be wise to take a look and analyze them. Take a look at the current ratios and things like that and see if we're starting to get in trouble.
Representative Hallinan. You're muted, Representative Hallinan.
Thank you, Madam Chairman. My question is, how much of Part C is paid for by the feds? And this cut doesn't affect that. So how much is left? What is the percentage of the cost of Part C is the general fund?
Ms. Babbitt.
Madam Chairman and Representative Hallinan, almost 90% of our budget for the providers is general fund money. And the remainder then comes from the Fed.
Thank you.
Thank you. Okay, so committee, I think, we'll move on. There's obviously a lot here that we could probably spend a lot of time on. One thing that I'll just point out as we go into session, when JAC meets in December and January to do their agency hearings, in the past, because I'm here in Cheyenne, I have sat in on those, and occasionally one of them will graciously call upon the Chairman of Labor to make a few comments. One of the things that as committee members, we'll just really need to consider as we go forward, so much of what we handle in our committee, and then also Department of Corrections type issues, are situations, whether through DFS and foster children or Department of Health, mental health and substance abuse, these situations with children with potential disabilities, where prevention and early intervention are really what is needed and what saves a lot of money farther down the road. And I will just, and this is just my personal opinion, but we all need to really consider it and talk to our desk mates and all that. In difficult budget times, there are a lot of things that we all really like. Parks and public radio, not to call out anything specifically, but libraries, wonderful things that we all really like. But personally, I am going to talk to JAC people and say that I think they need to be the very most cautious about cutting dollars that will end up costing us more later. And that's just something that we'll all have to consider going forward. Representative Barlow.
Thank you, Madam Chairman. Just to add to that, as a member of the current recalibration committee, education recalibration, the legislature requested an assessment of special education, and that report is available through the recal committee in our October meeting. I think our members who are interested in this issue might find some interesting observations that the consultants provided both to the recal. Subsequently, that'll go, of course, to the entire legislature. It's obviously available to the public and the entire legislature. But to your point, there is more information out there on the K-12 nexus and some of the considerations we should be considering there. So thank you, Madam.
Thank you, Representative Barlow. Is that document on the recalibration committee's website of materials?
Madam Chairman, I'll send a link to their report.
Great, thank you. That would be very good. Chairman Scott.
Madam Chairman, can Representative Barlow give us a 30-second summary of the thing as to what's in the?
Yes, Chairman Scott doesn't want your link, Representative Barlow. You're still muted. Oh, there you go.
Madam Chairman, I think that what they've done is they've outlined some of our strengths and some of our opportunities. And there are certainly some strengths within the system we have, Madam Chairman and members of the committee. But they also believe that, and this, I think I would characterize it, we don't have big mistakes, but there are potential for efficiencies and delivery improvements that would be both beneficial to the students, our primary goal, and improve potentially the challenges we have with our funding. So I'll just give you a few things. Now, I guess what I should preface by saying, they don't talk about how kids enter K through 12, which is what we're talking about with Part B and C. What those children, how those children are identified, etc. But first, they don't believe that we're over-identifying. They believe that that we are within the norms and what we would expect. They don't speak about whether our early interventions are being effective enough. And that could be something that if we wanted to ask them to back up and take a look at our Part B and C and the effectiveness of it, these folks might be the folks to help flesh out that component as well. And that may be well worth doing or looking at as well as a value to the entire system. So I guess the bottom line, what they say, I think, is that they say pay more attention to how dollars are spent, not just how much is spent. They want more general access in K-12 now, more folks to be inclusive instead of excluded from the general ed classroom. They think there should be some level of caution about over-identification, which was Chairman Scott's discussion earlier. And then they also talk about the need to consider the really high cost, high need children separately. And this is also, of course, a discussion to be had within the Part B, C potentially as well. And then anyway, those are kind of the takeaways. I mean, I think you'll find it to be interesting and I think well referenced in their recommendations. So that's more than 30 seconds and it's not a very accurate summary probably, but I'll send the link to all the members. Thank you, Madam Chairman.
Okay. LSO, have we got some folks who want to make public comment on this report?
Ma'am, yes, we do. We have 3 individuals who signed up to speak about this,
Very
Alicia,
good.
Jamie, and Davey, and I will allow them to all enter at the same time now.
All righty. Okay, let me see if I can line up my list here. Sorry, the screen is just not big enough here. Looks all right. Roan, Stein, and Howe or Huff. Sorry. And I apologize if I've gotten your name incorrectly. I'll just start on the top of my list. Ms. Roan, is that or please state your name for the record.
Yes, thank you, Madam Chair. My name is Alicia Roan. I am the Executive Director of the Child Development Center in Natrona County. And with me today, I have Jamie Stein, who is the Director of the CDCs in both Albany and Carbon County. And then Davey Huff is the Special Ed Director in Teton and Sublette counties. And we just wanted to give a short presentation on the impact of the cuts to our program and what the future looks like for the CDCs moving forward. Could I have approval, Madam Chair, to share my screen for the presentation?
That will be fine.
Thank you. And I also wanted to give a special thank you to Representative Sweeney for reaching out to us to comment on the cuts we've received, as well as the continued support that we have received from many of you on this committee. So I'm going to share my screen with you. Hopefully you can all see that.
Yep, it's up.
Okay, perfect. Thank you, Madam Chair. I always like to start our presentation just introducing you to one of the children we serve, and this is Braden. Braden is diagnosed with Cornelia de Lange syndrome, Pierre-Robin sequence, radial ray syndrome, microcephaly, cleft palate, moderate to severe hearing loss in his right ear, severe hearing loss in his left ear, and visual impairment. Now, this is, of course, one of the most severe cases that we have at our center, but we've worked with Braden since he was an infant in the Part C program. Now Braden is in the Part B program. As you can see, Braden doesn't have any forearms or fingers. So CDC has been utilizing his strengths, which are his feet, to communicate. This past month, Braden reached a huge developmental milestone by recognizing that if he presses on a switch, which is a communication device that speaks for the child, he can communicate his needs with us. He now uses the communication devices with his feet to say, "Hi, my name is Braden," or "I'm hungry," or "go," in this case, for the car to go around the track. We can now support Braden with his needs through him communicating through his feet. This is something that Braden's parents and physicians never thought he would be able to do, and they attribute that progress to his early intervention. I just wanted to touch base on the reductions that my program alone has seen through Part C. And as was stated in the committee meeting, the Part C per child amount decreased by $2,000. So we now receive $6,908 per child to provide speech, occupational therapy, physical therapy, cognitive skill development, and social emotional therapy. And for me, that was a total budget cut of $270,846 to my program. But yet I'm still having to meet the same state and federal requirements for 143 infants. Currently, as we come up to our December 1 count, my count is down by 70 children in both the Part C and Part B program due to COVID. Because many of our local daycares and preschools aren't letting additional visitors in to screen children. Parents don't want to bring their kids in to be screened or evaluated due to the virus. And so we've seen a huge decrease in our counts across the board at every CDC. For me, if I am down 70 children by December 1, that would total $641,900. And again, this is just for Natrona County. We can't apply for the CARES Act funding towards this amount because it will impact us next fiscal year. And that impact on my program would be about 30 staff. So my total predicted loss for this next fiscal year prior to receiving yet a second round of cuts would be $912,746. When we visited with Director Sabias and Matt Petrie regarding the cuts, they both said that there was a potential of completely eliminating the Part C program for infants across Wyoming, which would impact, again, a total of 1,207 infants and families receiving services. And I recognize Matt Petrie saying that this program is optional, but in my mind, it's not optional. We as a state have an obligation to serve these infants and families so that they're not further behind when they reach age 3. So I truly feel this cannot happen. And I know there was some question as to whether this would heavily affect Part B, not just the cuts for Part C, but the elimination of Part C, how it would impact Part B, and it would greatly impact Part B and our child find numbers. Because again, children wouldn't be able to get services until they turn 3. So the fact of us trying to find these children when they're 3, rather than getting them right out of the gate as an infant with a disability, would severely harm Part B services. I want to turn it over to Jamie Stein to talk about the impact of budget reductions on Carbon and Albany County. Jamie?
Thank you, Madam Chairman, committee members. Again, my name is Jamie Stein, and I'm the Executive Director for Developmental Preschool and Daycare Center based in Laramie. And I also operate the CDCs in Carbon County, of which we have 3 different locations in Carbon County, 1 in Encampment, 1 in Saratoga, and 1 in Rawlins. We are looking at a cut of about $37,000 in Region 8. Almost 155,000 in Region 11 for a total of $191,000, which doesn't seem like a lot, except for when you look at the total amount. We're already operating at bare bones, especially in Carbon County. I don't have any staff that I can cut. And so we're having to absorb those cuts through some very limited reserves that we have available in our financials right now. So there's really no other way. You know, we have not been able to do fundraisers this year because of coronavirus and the fact that events have just not been something can done because of public health orders and things like that. So we're down all of those fundraising monies as well that we really depend on. In addition, we are looking at being down a total of 23 children across the 2 regions this year for our December 1 count. And that's our best guess as of right now. We're still in the process of doing evaluations. And that's best case if everybody that we're currently evaluating does end up qualifying for services, which is the early case. The only other option that we have is to reduce staff hours. To try and decrease our staffing costs, which is our #1 cost for our facilities. That's not always possible because if we decrease staff hours, we run the risk of our staff quitting and going on to greener pastures somewhere else, whether they go to the school district or whether they move out of our communities. Those are all very real possibilities. And if we lose our staff because we can't pay them a full-time rate, we can't provide the services that we're required by law to provide. So those are really big concerns for our centers on an ongoing basis, not just this year, but it has been an ongoing battle. Certainly we're feeling the pinch a lot more, and we're doing everything that we can to continue providing services to kids, families, regardless of what we're being paid to do so.
Okay, great. We'll move on to the next slide. I know that Heather Babbitt, and let me mention, we love working with the EIP. They are great supporters of ours, and we really appreciate the staff. As Heather stated, the cost study showed expenses of $11,078 per child, which was not adjusted for infrastructure, et cetera. So CDCs receive for Part C, again, that's the infant program 0 to 2, we now receive $6,908 per child to serve them for the year with the services outlined below. Part B, we receive $8,674 per child to serve them for the year. Let me mention that in the school districts, they receive about $18,000 to serve the child for the year in special ed. all CDCs have to maintain our own buildings, busings, etc., aside from providing services to the children with the limited funds that we receive. Therefore, each of us heavily rely on fundraising to be able to provide the best programs for these children. Each year, I raise about $500,000 per year to make my program the very best that it can be, with the shortage in funding that we do receive. Jamie.
So I am really enjoying the fact that I have been able to participate in the governor's task force on early childhood. It has been a great opportunity to be at the table and make sure that the CDCs have a voice in this process. And I'm really excited that the state of Wyoming is looking at this and is focusing on the importance of early childhood as a whole. There are pretty much representatives from all different types of early childhood programs that are participating on this task force. There's representation from every state department that has a hand in early childhood. And so that is a really great thing. And it's a really great thing that the state is focusing on. We are in the process of making a recommendation to the governor regarding consolidating early childhood programs, either under one or two different state departments, and that there is some draft legislation that is being written as we speak right now based on what those recommendations are. I think it's a really telling thing at the state level that we're putting a focus on the importance of early childhood. And I heard some people talking about that, some of the members talking about how important early childhood is. And I'm not just talking about the early intervention, but early childhood education and care as a whole is so, so important. And I just really appreciate the opportunity to participate in that and urge all of the members to be looking for information on that as it rolls forward and as it gets communicated out. And to please keep that in mind as recommendations for further cuts or potential loss of our Part C program could be detrimental to the state as a whole. And something that, I think all of us in the state of Wyoming need to focus on.
And as it says on the bottom, Child Development Services, which is our association that the Child Development Centers belong to, are right now neither for or against this recommendation until we truly see the draft legislation and what it would mean for our programs. So I know there was some discussion in the committee meeting about, CDCs remaining viable. And I think some of our centers are at that point where we will not be viable if we continue to take additional cuts with our upcoming count. Because as Heather said, even though our count is on December 1, we serve more children than that December 1 count throughout the year. So for my program alone, with the cuts and decrease in the count, I still have to serve 375 children with special needs and 135 children without special needs because we have a great inclusion program. So we serve both children with and without disabilities. But we still have to meet the state and federal requirements regarding service times. And as I said before, when my program is looking at close to $1 million cut for this year, I don't know how I can continue to remain viable and serve these children with the much needed services that they need if we in turn get a second round of cuts. Eliminating Part C cannot be an option. It will cripple these programs. And I urge you to think of what would happen to the 1,215 children or infants that we currently serve. What would happen to Braden? He would be so far behind if we didn't start with him as an infant. For us CDCs, we saw what programs took cuts under the Department of Health and what programs didn't take cuts. And we were devastated by that 22% cuts that the individual centers took right out of the gate. We continue to hear the governor say programs can plan on 10% cut now and 10% perhaps later in the fall. but to receive 22% out of the gate was definitely harmful towards our programs. On top of that, we're impacting their little lives. Like Representative Sweeney said, you know, we are their voice because they're too little to voice their support for early intervention. And so we have to put them at the very top of our minds. So today, what we are requesting is to not receive additional cuts, and certainly not the elimination of the Part C program. Because if we were to do that, again, I'm not sure that our programs could remain viable after serving our communities for over 50 years with early intervention services. I really appreciate this committee and the support that you have had for us in the past. And I would hope that your influence on the Department of Health could just encourage them again to keep our programs top of mind and not provide any additional cuts to these children and the services that they need. With that, I'm going to leave you with one last story so you keep these kids again top of mind, and we can open it up for questions from the committee if you'd like, Madam Chair. So this is Noah, and Noah was born with a formation on his right cheek that after several tests was determined to be a microlymphatic malformation, a mass of tissue that is not cancerous but continues to grow. He's had 2 different surgeries before he was 2 and recently went under another surgery to decrease the size of the mass. If the mass was not decreased, it would take over his eyesight as well as grow down into his throat, thus impacting his breathing. Both surgeries, or all 3 surgeries, have been very risky, and there are only 3 doctors in the US that will perform surgeries like this on Noah. As Noah grows, he will have to have more surgeries to hopefully continue to decrease the mass. But right now, the mass is affecting his vision, eating, drinking, and speech. He has been receiving services through CDC since he was 1 year old through the Part C program. He was provided with speech, early intervention services, and physical therapy because he did not start walking until he was 15 months old. When he turned 3, he transitioned into the Part B program into a therapy-based classroom. During Noah's preschool day, he's provided with speech therapy, social skills, cognitive skill development, and occupational therapy, as well as learning how to be more functionally independent. Noah's parents also attribute his developmental progress to CDCs and early intervention. So again, I pose the question to this committee: where would Braden and Noah be without the services that we have provided to them? Again, we just want to thank you for your time today and for your continued support of the Child Development Centers across the state.
Ms. Roan and Ms. Stein and Mr. Huff, thank you so much for the services that you provide to these little folks. Do we have any questions for the presenters committee, from the committee? Representative Yin.
Thank you, Madam Chairman. Maybe I missed it in the presentation, but what do you think the likelihood of, maybe if you give like a percentage number of CDCs having to shut down if we had more cuts in Part C or Part B?
Ms. Roan.
Thank you, Madam Chairman, Representative Yin. You know, for my program, we are one of the largest in the state. And so, again, it would be, the cuts that we receive, obviously, I'm going to have to decrease staff and figure out how I can continue to run my program and raise funds to cover those cuts. But my biggest concern is the smaller programs throughout the state, like Jamie said, up in Carbon County, just the smaller CDCs, you know, in Buffalo and other areas, smaller towns, Newcastle. I don't know how they would be able to continue with additional cuts. They are already at bare bones, and maybe Jamie could better speak to that.
Ms. Stein.
Thank you, Madam Chairman, Representative Yin. I can speak to Carbon County specifically, and in my 2 regions, Carbon and Albany County are very, very different. Just because of the size. Carbon County is about 1/3 of the size of what, or as far as, you know, funding and number of kiddos that we're serving as what Albany County is. So Carbon County in order to serve all of the kids through Part C and Part B, we share the same staff. Our staff work with all kids that are in our program regardless of age. And so further cuts on the Part C side really impacts our ability to be able to serve Part B kids. As I said before, if we have any further funding cuts, I have to reduce staff time, which means I'm cutting salaries to our people, and our staff are not able to live on those salaries if they're reduced from what they are. And so they will be forced to make a choice of either, taking the salary cut or, quitting their job and moving somewhere else where they can find a full-time job. And if I don't have staff, I can't serve these families in the communities that they live. And so for Region 8 specifically, further funding cuts will be detrimental and could potentially result in those programs closing.
More questions? Representative Sweeney.
Thank you, Madam Chairman. To any of you on professional staff, you just don't hire somebody off the street to work with these kids. So I know for a fact that you've got speech pathologists, but are the teachers certified teachers through the normal process? If you could just explain that to me, because I'm not totally aware of what the professional staff is and certifications.
Ms. Roan. Oh, you're muted.
Thank you, Madam Chair and Representative Sweeney. You are correct. We have to have professionals, the speech language pathologists, physical therapists, occupational therapists. All of our teachers have degrees, and some have dual degrees in special education as well. And so what we're seeing is not only is there a shortage of speech therapists in Wyoming and occupational therapists and special education teachers, but we are competing with the school districts on the staff, because obviously we cannot pay our professionals the same amount of salary that the school districts can pay, nor give them the same benefits. My school district recently was giving a $12,000 sign-on bonuses for speech therapists, and I was devastated because I can't offer that. The best thing I can do is offer them kids that love the heck out of them, but I can't compete with that. And so we are constantly trying to maintain our staff to serve these children.
Representative Clem, did I see your hand?
Yeah, thank you, Madam Chairman. On that note, appreciate your testimony. Sounds like you've had significant amount of cuts. In your school district, how much cuts have your school district had?
Ms. Roan.
I can't speak to that. I know that there was an article recently published about the potential cuts that they will be receiving, and they sent out a survey for public comment on perhaps where our school district could best take those cuts to the community, which I thought was interesting. But as of right now, I do not know the cuts that they currently have received.
Thank you, Madam Chairman. And I think that answer is zero. In fact, they've had zero cuts for a significant amount of time, while programs like yours has taken cuts after cuts after cuts. Thank you.
More questions from the presenters? Okay, I think we've got some more public comment on this. Thank you so very much. Chin up, we love you. Please don't stop doing what you do.
Thank you to all of you. Again, Madam Chair, Senator Scott has been a huge advocate for us, and we love you. We love all of you for your support, and we're just trying to stay alive at this point in time. And so thank you so much for giving us this opportunity.
You bet. Thanks very much. Okay, Alyssa, who have we got next? Let's see. Oh, sorry. I guess I can call upon people. Or no, all three of those were the same commenters. We don't actually have anyone else, do we, on this topic?
Madam Chairwoman, no, we do not. The next topic has quite a few number of folks.
Okay, well, because the next topic actually does have a number of comments, let's take our coffee break now and come back. Let's see, it says 7:39, sorry, 9. Let's come back at 9:50 and we will hear about the reports on House Bill 103. 9:50. Make sure to mute yourselves while you go away. Co-Chairman Scott, you're muted still.
Madam Chairman, are we ready to start up? Because I do have one piece of information relating to a question that came last time.
Okay, LSO, can we go ahead and start again?
Madam,
Ma'am, you're still live.
Okay, we're still live. All right, go ahead, Chairman Scott.
Madam Chairman, with regard to the question that Representative Clem asked for the school districts, I had part of my general preparation for things. I had asked LSO for summaries on the K-12 spending. And through 2016, they were increasing steadily. That ended after 2016. In the 4 years since then, they've been essentially flat. There was a net reduction. There were reductions in 2 of the years, increases in 2 of the years, and the net is a change of a slight decrease in the vicinity of 1% of total. So that's the overall. Doesn't say anything about special ed funding as opposed to everything else. It's just total school funding. Did over that 4-year period go down by about 1% in total.
Very good. Okay. Is the Department of Health ready to pick back up with the reports?
Madam Chairman, members of the committee, we are.
I hear your voice. I see a black rectangle. Oh, there you are. All right. So this is a committee. This is a report on a bill that we had in 2019, House Bill 103, reporting of abortions. I just felt like it would be a good opportunity to kind of circle back and make sure that things were going as intended. When we have, just like last year, we had that bill on Medicaid birth cost recovery, you'll recall, and we followed up on that. So I think it's always good when we have subject matter that pertains to our committee for us to follow up on bills, even when they're not committee bills, as that one wasn't either, to just see how things are going. So go ahead, Franz.
Thank you, Madam Chairman. Again, Madam Chairman, members of the committee, my name is Franz Fuchs. I'm Policy Analyst, Department of Health. And just here to give you a brief summary of how the abortion reporting statute changes have been implemented. As you all know, Wyoming Statute 35.6.108C requires the Office of Vital Statistics to issue a public report regarding annual abortion summary statistics from the past year. So it does say that, it cannot be to the level where it's reasonably leading to the identification of any woman, but we do try to report in detail, some of the, I guess, salient features of what's required. So VSS has had no trouble getting this data from providers. They published a report on June 18th publicly. It's 6 months worth of data covering July 1st through December 31st. And we continue to get reporting. So we'll just keep updating this report as we go. Just in brief summary, in the 6-month reporting period, so again, this is half a year, we had 31 total abortion procedures that were reported, 26 from residents, 5 from non-residents. So if you obviously multiply that by 2, our annual estimate would be 62 for the year. All of those patients were early medical or non-surgical abortions, and with the average gestational age of 6 weeks. Most of the patients were between the ages of 25 and 34, and 61% of the patients reported the procedure as their first procedure. So just some facts from that report, but other than that, I have nothing really to report other than the report is out there, and we have had no trouble getting the data from providers.
Thank you, Mr. Fuchs. So I have a couple of questions, and no doubt there will be some. When on your report it says facilities continue to submit required documentation. So do you receive reports from all obstetricians in the state, or who are you expecting to hear from, I guess?
And Madam Chairman, I apologize. I don't have the level of knowledge to the nuts and bolts of the reporting. I can ask our state registrar, Guy Bedoin, to come on the call and answer more detailed questions about the nuts and bolts of how the reporting is going. I'm just a hack here to give a couple slide overview on on the report itself. But
I think that might be helpful as we go forward, and then I have a separate question, which because I did see, and it's not in this, so I don't recall where I saw it, but the report was evidently labeled something along the lines of involuntary termination of pregnancy, and I guess I'm puzzled by whether we could reasonably expect the data that we think, when to me an involuntary termination suggests a miscarriage rather than an abortion. I mean, it's kind of hard to, I mean, maybe the Uyghurs in China are having involuntary terminations, but generally when you have an abortion, it's voluntary. So I don't understand the form. So whether you know, or maybe Mr. Bedoin could show up, would be helpful. Do you know the answer to why is the form titled that?
Madam Chairman, I don't know. I've asked Guy to join, and hopefully Elizabeth, when you see him, you may be able to invite him. But I would only suggest maybe there may be some folks with public comment that could use to fill the time until he or to testify before Guy gets here.
Okay, well then, any questions for Mr. Fuchs, who perhaps may not be able to answer your question, but are there any questions? We can kind of collect hands meanwhile. Any questions just for Mr. Fuchs? I do not see any hands. Okay, so then we've got, well, pending Mr. Bedoin, we will see, let's see, we've got,
Madam Chairman, I think Representative Yin had his
Oh.
hand up.
I beg your pardon, Representative Yin. And you're muted.
Whoops. Madam Chairman, I just wanted to point out, I went to the Department of Health Vital Statistics Services website, and the form is actually induced termination of pregnancy and not involuntary. So I'm not sure where the term involuntary got pulled from, and I suspect it's just a typo or something.
A typo, yes. So that was certainly puzzling. Induced, very good. So all of you who are going to comment on the involuntary, you may find out that the person who typed the report typed it wrong. Representative Stivard, did I see your hand waving? Or you were just pointing at Representative Yin? Okay, Representative Clem.
Thank you, Madam Chairman. And I just wanted to point out one thing. My name is on the screen twice, and that's because I'm going to have to go mobile here in a second. So LSO was gracious with me. So that is the same person on there. I'll just be exiting here in a little bit.
Okay. I thought that was your final benefit as vice chair, to be labeled twice.
That's right. Yeah, I've got to go and over to the Camplex to oversee some arrangements for Representative Edwards' funeral. So there's a couple things when we consider this. We passed this piece of legislation in 2019 because we were not getting the data from providers as far as how many abortions were actually taking place in the state. We had independent organizations like the Guttmacher Institute that were reporting significant amounts of abortions within the state, whereas at that time in 2019, we had testimony from our state health officer that we have had less than 5 abortions in the last 5 years. In particular, it was 4 abortions within a 5-year period. So we knew that something was off. For perspective, in 2015, there, I believe, were 110 abortions according to the Guttmacher Institute, 140, I think, in 2016, and 120 in 2017, and that's the most recent data. And of course, the idea here is in order to ensure that we have good public policy, we need to ensure that we have good data. So still a little bit concerned because I picked up on the same thing on that report, involuntary, termination of pregnancies, which I think we need to get some clarification what that means, because it does seem to imply that it's a miscarriage and not a voluntary procedure, which is what an abortion is. And so I really just want to make sure that we are getting accurate data, and that part of the reason for the update to this law was to ensure that that providers were indeed following the law, which they were not for a very long time. And so we added an enforcement provision And so you really want to see if this law is working as intended. If not, then what can we do different? So thank you, Madam Chair.
Okay, more questions? Any more questions for Mr. Fuchs? Okay, while we're waiting on Mr. Bedoin, why don't we go ahead and let in the public comment? Some of them I'm sure have been patiently waiting. We seem to have 1, 2, 5, I think, on this subject.
Ma'am, we also do have Mr. Bedoin here now, if you would like
Oh,
to
good.
ask questions.
Scott, where are you? Where's your rectangle?
I think top left on my screen.
Is that you? Oh, there you are, Guy and Marianne. Okay. Sorry, it's just, all right, folks, Guy, the rectangle labeled Guy and Marianne is Scott. You might, if you're, I presume that's your wife, if she doesn't mind you taking her name off just for now so that we are not, there we go. Now we can just make sure we understand which. So while Mr. Bedoin is here, before we get the public comments, did we have questions for Mr. Bedoin specifically? So you are the, if you could just introduce yourself, what your Director of Vital Statistics, or what's the formal title?
Yes, Madam Chairman. Guy Bedoin, Deputy State Registrar. So Director Savias is the registrar by statute. So, and our office was tasked with receiving the reports for the annual reporting of induced termination of pregnancy.
Okay, very good. So I have 2 questions to start with, which was, I had seen a report and I don't even remember how I got it. And the I seemed to be listed as involuntary, but I see perhaps that was a typo and it should be, and that's labeled as induced. Is that what we understand first?
Madam Chairman, that's correct. It is induced termination of pregnancy.
Okay.
So there is, these procedures are of course voluntary when approached, when the individual approaches the physician.
That was certainly what was puzzling me. The other question I have is the report that Mr. Fuchs presented stated that, and sorry, I need a much larger computer screen because it's gone off the page now here. Says facilities continue to submit required documentation. So I'm just wanting to understand, do you get or expect to get reports from all obstetricians? I mean, I remember when I worked in healthcare that we used to say, if you didn't write it down, it didn't happen. So do all obstetricians send in a form and some of them say 0, or who, when it says facilities continue to submit, who are you getting them from, the forms from?
So, Madam Chairman, only those facilities that perform the procedure are required to report. So if the obstetrician does not perform the procedure or it isn't in their list of services, they do not report. So we did a couple of things with some of the facilities across the state is we asked them if they would go in and search the database for ICD codes that had to do with any of the termination of pregnancy. And when asked, the 2 that we sampled, they ran those reports and there were no codes that came back across that said that they were being performed. So along with Dr. Harris, we've asked the facilities to volunteer this for us to kind of do a kind of a quality assurance check to see if they are in fact following the statutes. And the 2 that we did work with, they came back, the reports were no. So these are only those providers that are providing that service and have provided it are sending those reports to us.
So then one last question, and then I'll open it up to some other questions. So, according to this, it looks like the only abortions done in the state were medication abortions and no surgical ones at all, which seems, I guess, hard to believe, although interesting. And then I heard from elsewhere, I wasn't there, that in the testimony on a different bill last year in the Senate, there was discussion of terminations of pregnancy that occurred in the 2nd and even 3rd trimesters, which don't show up on this. Do you have any thoughts on that, or whether there's something there that is not being captured somehow?
Well, Madam Chairman, I'm not sure if, so with regards to the form that we have and the way the statute is written, I think that, as you noted, the early gestational age for those that are receiving, and this is basically the day after pill, I believe is the kind of the market term for the type of abortion. But I think that any of those late term abortions are potentially being sought out of state. And that's only speculation. I don't know. We're only able to interpret the data that we get on the form, and the data that we receive is somewhat limited also by law because of the confidentiality elements that have gone into the language.
Okay, questions for Mr. Bedoin? Chairman Scott, do I see your hand?
That's right, Madam Chairman. When we had this bill in Committee 10 on the Senate side, one of the things we discovered was there was a great deal of misunderstanding within the medical community, because they will report and think of things that we would call miscarriages as abortions, call them spontaneous abortions. And that was causing a lot of confusion. And I think when you see things talking about involuntary terminations of pregnancies and calling them abortions, you're getting people that are using that set of definitions. We tweaked this legislation trying to be very careful that what we were really asking for was just the ones where it was an intentional termination of pregnancy. And the question I've got, it sounds from what I've heard from Mr. Bedoin that we are in fact pretty confident that that's our data is what we think, and we aren't getting any of the miscarriages reported, that confusion has been successfully dealt with in the reporting for this. And I would also add to what he said that my understanding is that the more complicated ones that are later term done for some medical reason are often referred out of state where they have the experience to deal with them. So question for Mr. Bedoin is, are we really confident we've got this data clean on this?
Mr. Bedoin.
Madam Chairman, Senator Scott, I guess I can only comment on the data that we get, but I guess to your point, the confidence level is that previously we weren't receiving reports like we are today. So I'm confident that the providers understand the requirements that have been put into law, and I'm confident they're following it because we are getting those reports to us. As far as the definition between the, that spontaneous abortion or miscarriage, I think those are classified as miscarriages, and technically we don't get any of that data. So, and I don't know if maybe Senator Baldwin, he works in the field. I don't know if he has any information that he might be able to provide, but I think the definition there for the abortion is one that is induced, and we are receiving those reports.
So, and then one last question, and Mr. Bedoin, you may not know, but so Representative Clem, I mean, I'm a little concerned that we've swung from one side of the pendulum to the other, perhaps previously collecting too many, and now I just wonder the Guttmacher information, which I think is voluntarily reported by providers to Guttmacher, I think, I'm not really sure. The last data that and Representative Clem has gone to phone, I'm not sure if he's still on, but it was like 150 or something. And so, and with this only being medication ones, it looks to me almost like any surgical procedures are no longer being reported at all. I mean, I'm just not, I guess I don't have quite your confidence. That doesn't seem to make sense to me, but I guess you only know what you've got.
Yes, Madam Chairman, that is a correct statement with regards to, I mean, we have to go with the information that we get, but I do think too, as was noted, some of the late term abortions, Guttmacher does report resident data. So if an individual was a resident of Cheyenne here in Cheyenne and Laramie County and was looking for a procedure, more than likely they went to Colorado and or another adjoining state and were able to have the procedure there. Guttmacher would report that as a Wyoming event, much like we do with occurrent and resident reports also. So I think that's an important piece to note, is that looking at the abortion may have occurred in another state, but it was to a resident of a specific state.
Yeah, well, although last year I looked at the Guttmacher and it looked to me like there was actually Excel reports and they had abortions done in the state, but also people from somewhere. So you could actually look at people from Wyoming who had abortions in Montana and Idaho and Colorado and such like. So I think you could parse that out. But anyway, I'm asking more questions than you probably have answers for. Okay, if there's no further questions for Mr. Bedoin, if you'll hang on, because I'm sure probably something will come up. And again, you know, we just want to make sure that we got the bill right the first time around and that people understand what we're doing and that the form is what we want. And LSO, have you let in the public commenters?
No, ma'am, but I will do that at this time. You do have several individuals, so.
All right, let them in. And I will find my paper.
And ma'am, in addition to the list, you may also note that Marty Halverson is also here to provide comment as well.
Oh, okay. Well, where'd she go? I'm going to call on Marty first in recognition of her past involvement in this committee. Welcome back to the committee, former Representative Halverson. Make sure to unmute yourself. You've not suffered through as many Zoom meetings as we have, perhaps.
Okay.
Welcome back, Representative Halverson. Don't you wish that you were here on Zoom meetings with us all summer long?
Oh, I've been on plenty of Zoom meetings. I don't know that I could have added any more.
Okay, I know the feeling. Please, what is your comment?
Thank you, Madam Chairman. First of all, just a very technical question. I know that the latest report was for 6 months, and we would just like to know when the next report is scheduled to come out. Will it be calendar year? Will it be July 1st to June 30th? If we could just know what to expect going forward with these reports, that would be very helpful. The reporting of abortions law has been in effect since 1977, yet neither the Wyoming Department of Health Public Records designee or the Office of Vital Statistics was able to provide us an answer to our request for a compilation of reports prior to 2019. My request of committee members today is that you ask the Department of Health to compile Wyoming abortion data for the past 7 years. It's our understanding they don't need to maintain the information after 7 years, and make this information available to Wyoming Right to Life or our affiliate physicians upon request. Ideally, for the sake of full transparency, this compilation should be publicly available. And we would ask this committee to consider incorporating that into 35-6108. As to abortions by age of patient, this committee and the people of Wyoming should know and should be able to tell us if any of the quote less than or equal to 24 patients were minor children. Wyoming Right to Life requests that future reports and compilations of the requested prior year's reports include that information. This report, to my way of thinking and Wyoming Right to Life's position is that it is unsatisfactory on many levels. This report raises more questions than it answers. It, frankly, according to others in our organization, seems cursory and minimal. Our members wonder why more comprehensive data is not available. We would also ask that future reports include definitions. I think we have been satisfied on the involuntary abortions being a typo. We would like this current report to be corrected to reflect that before it gets more widespread. We would also like a definition, and we would like to know if medically induced miscarriages of healthy babies is considered an abortion in the definitions. With the utmost respect for beloved Chairman Scott, the miscarriage term as used during testimony last year was only muddied. And due to the testimony we heard that included the phrase medically induced miscarriages. If that's not an abortion, I don't know what it is. We hope that future reports will look much different, will be more comprehensive, and that they are delivered to this committee by Mr. Bedoyne's office, Office of Vital Statistics, and their Vital Statistics Services people. I'm the last person in the world that thinks Mr. Fuchs is a hack, but I would, because I have the utmost admiration for him, but I would like someone less, I'm not going to use the word again. I would like someone with more information on this report to be delivering the required report. Mr. Bedoyne said that he is confident he is receiving accurate and all information. I was struck by his comment that providers were asked to go through their ICD, 10s now, looking for codes. And that raises a question for me. For example, under what code is medically induced miscarriage coded? Mr. Bedoyne said he receives info. I think I've been satisfied on my next question. Does he solicit information? And is the solicitation of the information comprehensive down to the level of, quote, medically induced miscarriages? So, Madam Chairman, that is all I have, but except for one more thing, sorry. Attached to my submission to the committee is the FOIA request that Wyoming Right to Life submitted to the Department of Health on June 8th, and the response received on July 9th, which was simply the VSS report, which was issued on June 18th, which I said raises more questions than it provides answers. So, Madam Chairman, that's all I have. If anyone has any questions, I will be glad to take them.
Okay, questions for Ms. Halverson? I will actually ask Mr. Bedoyne regarding one of the questions. In the future, will this be a calendar year report that comes out? Remind me, I don't remember the requirement as far as the periodicity of this report.
Madam Chairman, yes, this is an annual report. And to Ms. Halverson's point, I think that that's a good addition to the report is to include the definitions. So we will definitely do that. And we can also look at updating the report to ensure that all of the language is correct for this most recent report as well.
Very good. Okay. Senator Baldwin.
Thank you, Madam. I wasn't sure you could see me. Just a quick note on something that Ms. Halverson brought up to us about the definition of medically induced miscarriage. I believe that was a term. You can shake your head if you want, Marty. And I was just thinking about that. That's a vague term in and of itself, because there is an ICD-10 code. For instance, now let's put this in an example because parables are easier. If somebody's experiencing a miscarriage, but it's going very slow, the fetus has already experienced demise. It's not a healthy baby. And sometimes a drug is given to speed up that miscarriage. That is an ICD-10 code. I think that there is a discrepancy. I don't believe there is an ICD-10 code for a medically induced. It's not a miscarriage if it's not truly a miscarriage. It would be a plain just abortion if it's a healthy baby. So I think there is some confusion about the language there, but there is an ICD-10 code for when the miscarriage is occurring, and that is simply sped up to make safer for the mother, safer for the entire procedure through medication. I think that's something separate, and that's some of that muddy water we talked about, and I think that needs to be cleaned out as well. Thank you.
Mr. Bedoin, could you do, after the meeting is over, if you could do us a favor and email to all the Labor Committee a copy of the report that not what they have submitted, but the blank, I assume it's a blank form. If you could just send that to us so that we are, because I haven't looked at it, so that we can understand what we're asking for and what we're likely to get out of that, that would be really helpful.
Madam Chairman, yes, we can do that. I'll ask Franz actually to do that if he's got the form right there. And these are, the form matches the requirements in the statute. So, so we'll be able to see it both places, both in the language and then on the form.
Right. Well, and of course, we know that it has never happened that statutory language was clear, was unclear and wrong. So obviously there will be no problem. Chairman Scott.
Madam Chairman, for the committee's reference, there's two, if you look at the definition of what we're asking for, there's two things you've got to look at in 35.6.101A single I. There's a definition of abortion, which makes it clear that it is something that's taken or done to create the abortion. And then when this bill came through, your Senate committee added, and it became part of the statute, the 35.6.107D, termination of a pregnancy by natural miscarriage or as a treatment consequence of a natural miscarriage shall not be reported as an abortion. So, and then it continues from there. And says an alleged miscarriage that was induced with the intent of terminating a pregnancy shall be reported as an abortion pursuant to this section. So we've clarified it. I think we've got the statute pretty clear, and it sounds to me like the form, when we look at it, is going to echo those definitions in the statute, because the different uses of the terminology have muddied the water considerable, and your Senate committee went to considerable lengths to try to make sure that we were getting what we thought we were getting here.
Very good. Let's see, I believe that was all the questions for Ms. Halverson. Okay, next up, I'm just going to take you down in order that you're on my sheet. Mike Lehman is up next.
Thank you, Madam Chairman.
Lehman.
Thank you, Madam Chairman, members of the committee. Appreciate the opportunity to speak today, and I appreciate the kind of the difficulty in approaching this subject, especially in our freedom-loving state here. But we also know that individual freedoms are balanced by what we call the common good. Many of us have, just to give a little bit of a contextualized sort of setting for why we are concerned about this. Many of us have witnessed ultrasounds of unborn children. And we can't forget those images nor the notion that the vulnerable unborn are a part of that common good. We maintain that it will be very difficult to heighten our sense of our shared social responsibility toward those experiencing systemic inequalities when we uphold a precedent that enables us to ignore an entire population or part of the population. A precedent that says what constitutes individual human rights is whether or not one is wanted. Now, my hope and goal these last few years as I've been following the legislature is to enable a more informed discussion on the issue. My questions are specific to abortion provider oversight. Where have we been? Where are we now? And where are we heading? That's been really difficult to discern because as we've already heard this morning, there are common claims that come about. There are only 2 providers in the state. I've heard that for years. Most women who seek a late-term abortion or other abortions for that matter tend to go out of state. We hear a lot of these claims, but we wonder where the evidence is. Well, it seems like it's the lack of evidence that is given most often to affirm those things. We know, we just heard Ms. Halverson mention that since 1977, since I was 5 years old, there's been a law in the books requiring abortion providers in the state to report, but it's been largely ignored. And we know this because the Guttmacher Institute's reports suggest that there have been many more happening in the state for the last 4 or 5 decades than the state was made aware of. And then a few years ago, we had 2 providers publicly admit that they ignore Wyoming law and that they know of other providers who ignore it as well. It was this above the law mindset that led to the passage of the 2019 reporting bill, creating the fine for non-compliance. Last session, we also heard a claim that post-viable abortions are illegal in Wyoming. And therefore, there's no need to pass the Born Alive Infant Means of Care bill. But as was pointed out in debate on the House floor, there is a health exception in Wyoming law, which does allow for late-term abortions. In Doe versus Bolton, the Supreme Court said the health exception for the mother includes, quote, all factors, physical, emotional, psychological, familial, and the woman's age relevant to the well-being, unquote, of the mother. Now, one might imagine how subjectively this language might be interpreted, especially by providers who have a history of ignoring the law in the first place. It begs the question, if there's been no correction for non-compliance these last 40 plus years, are we very sure that they're all in compliance now? My concern is that most Wyomingites aren't aware of the possibility that human rights violations could be happening in their very own communities. Part of the reason we've been unaware of that possibility, I think, is that we don't really want to know. But we're not going to stop asking questions or talking about this because it's difficult. If we ever hope to have an honest discussion about this issue, we need those charged with oversight to make sure that we have clearly defined language in the reports and the providers are being compliant with the laws set forth by the legislature. Madam Chair and members of the committee, thank you for this time.
Thanks very much. Questions for Mr. Lehman? I don't see any. Thanks very much. Okay, next up we have Mr. Hunter. Where his picture disappeared, where'd he go? I saw him earlier. Oh, here he is. Greg Hunter. Introduce yourself, please. Welcome to the Labor Committee. And you're muted. There you go. Good job.
My name is Greg Hunter. I'm from Laramie, Wyoming. I just want to say that I have read the induced termination report form a lot of times. And so that's kind of where my testimony comes from. Good morning, co-chairman and members of the joint meeting of the Health and Social Services Committee. I wanted to take this opportunity to thank you for crafting legislation that lets us peek behind the scenes of the medical professionals as they perform their Hippocratic duties with constituents. I realize HIPAA was crafted to protect the privacy of patients, as the right to privacy is enshrined in the Fourth Amendment of the Bill of Rights and is one of the most important, but seemingly least protected of our constitutional rights. But HIPAA gives the legislative branch great power in managing a constituent's privacy as they balance it with the needs of the state that is charged with protecting the general welfare of the people. While I believe in the right to privacy, I also understand that overzealous protection of personal privacy limits our understanding of the full story so that we can understand some conclusions about who chose to end a pregnancy, why they chose it, how it was performed, who performed it, when they chose it, and where it was done. Well, now that the state and we, the people, have seen the report, it is obvious that this legislation, the 2019 HB 0103 that resulted in the induced termination of pregnancy report, fails in some basic storytelling concepts taught in grammar school. As we only have a partial description of who had the procedure, a more full description of how it was done, we have when it was done, where it was done, but we really lack the most important part, why. So this report really needs some work on the why. Otherwise, we cannot make decisions to attempt to prevent or learn to live with these personal decisions. Also, when only a partial story is told, and the one that leaves out the why, it gives oxygen to conspiracy theories and or we go looking for why the why was left out. So I wanted to give you some examples of why and maybe the mindset of who made this personal choice. It is reported that over a woman's lifetime, 1 in 5 will be raped, and in some percentage of those raped will become pregnant. So were any of them raped? All of them? If they were raped, that leads to the whom, what, why, where, and when scenario. And this legislature has had every opportunity to pass legislation to reveal this story, but has chosen to abdicate. Was the rapist known to the women? Were they prosecuted? Was alcohol involved? Was the rape a result of a date rape drug like ketamine or GBH that this legislation failed to pass laws to track due to the undue burden on the veterinarian? Is it sex education, which Wyoming gets a D in? Was it a poverty decision? So let's go to who. The doctor that fills out the report is required to describe who and is very detailed in the drilling down of the Hispanic community, whose primary religion, in my understanding, is Catholicism, no matter if they are from Nicaragua or Guatemala. Seemingly, they are all very, the South American community are all very pro-family, as we can see on our 7 Catholic-trained Supreme Court justices. However, the preponderance of people seeking abortions are white women, but we get less detail about their countries of origin, as that may be tied to their attitudes about terminating a pregnancy. I don't know. I mean, we have no why, so let's think about it. So in my studying of the settling of the world and the migration of the people to Wyoming, is evident the predominance of people that settled, conquered this region were of Northern European extraction. And if you look at the countries that have allowed its people to make the most informed decisions about sex, abortion, and end of life, are those countries of Finland, Norway, Sweden, Denmark, etc. So maybe the who does matter, as the attitudes about personal choice may be a family tradition of this group of settlers. I will stop here and ask the legislature to go back to the drawing board and recraft something that tells the story of why things occurred instead of this story. In addition, if you crack open HIPAA next time, please provide information about the medical community that may be useful. For example, how much Adderall is in a community, as that has a direct link to how much meth may be coming to a community. Thank you, and I will take your questions.
Thank you, Mr. Hunter. Questions for Mr. Hunter? I do have one, and that's just certainly our goal, at least my goal in supporting the bill, was to understand what's going on better, provide better resources for people. But at the same time, we're trying to not reveal so much information that the individual patients could be identified. So I guess, how do you see that playing out in a relatively small state like Wyoming, if we asked for, and I don't have the form in front of me, but if we had, if it were to say that the person was from Niobrara County, there might not be that many. And then if you then identified that the person was 18 years old and it was a date rape, wouldn't that tend to I guess, how do you see the really good information not revealing specific individuals in small communities?
Thank you for the question, Madam Chairman. The discussion of HIPAA can get quite interesting, and I've had a lot of discussions with it. I had the discussion yesterday when I went down to a doctor's appointment. So I've discussed HIPAA a lot, and I think the level of detail that you drill down to with such a small data set that we're talking about would reveal something, but I think we could get information. And again, we're having doctors fill all this stuff out. So we're really having somebody's subjective look at something and fill something out based on discussions with them. So when I talk about, let's say Adderall coming into a community, I would love to know how many pills are issued, say, in Albany County. So and maybe based on age and gender of who that is. I don't think that would reveal anything. Your discussion about this individual person, I don't think I necessarily need to know their age or their county, but it would be nice to know if nice is a terrible word. It would be nice to know if this was a result of a rape or some sexual assault. And I don't think we have to necessarily give that by county. So I think each individual thing that we do to address HIPAA really requires some real thought. And I'm a big fan of I hate HIPAA. I understand it's supposed to be privacy. I love the Fourth Amendment. I don't really believe that you should have the right to ask whether anybody's pregnant or not. So let me put that down. But HIPAA allows us, the legislature, to let the public be informed about certain things that go on in the community. And I would really love to know that somebody is looking about how much GBH is looked at, but that got exempted. I would love to know how many opioids are flooding in. I was originated in Ohio. My attorney general was going after weed dealers when he could have looked at the DEA database and seen how many pills were flooding into the community. So the legislature has a very, very important role in telling the community medical information. And you're charged with that because an individual like me can't go to the medical community and say, I would love this data because I'd love to make some analysis. So really it is your charge to decide how HIPAA needs to be broken open and what information the public looks at. And this is the only report I can really look at that breaks open HIPAA information in a way that was interesting to me. As a matter of fact, I've written up legislation, marked up your HB 103 and your induced termination of pregnancy report and tried to submit it as legislation in March. At the March meeting when Dr. Harris T was there, I think Senator Scott, Senator Baldwin, it was one of your committees. So I'm trying to push that kind of stuff forward. I do believe a lot of these medical things need to be presented to us. I'm not really wild about this one. I don't think this tells us anything. I don't get it. But I want to use this example as an opportunity to implore the legislature to do more of this work. And I commend you for doing it. Thank you.
Okay. Any further questions for Mr. Hunter? Very good. Thanks very much. Okay. Next person up is Jonathan Lang. Is he still here? Oh, there you are. You're muted though.
Okay.
Good morning, Pastor Jonathan.
Madam Chairman, Mr. Co-Chair, thank you for giving me the opportunity to address you this morning. So I am Jonathan Lang. I'm a parish pastor in Evanston, Wyoming, and a member of the Life Ministry Advisory Committee of our church denomination. It's my understanding that you all received my public comments, so I don't want to repeat any of that here. I only want to drill down on just exactly how does the 2019 summary statistics report that we are considering, how does that intersect with other published data about abortion in Wyoming? For your help, I also emailed you a copy of the PDF from the Guttmacher report, which was issued a year ago now. And I'll be referring to that here in my comments. 3 points, really. At the most basic level, the Guttmacher report indicates that the implementation of Wyoming's abortion reporting statute is only documenting half of the abortions that the nation's leading abortion research organization is documenting. So Chairman Wilson already mentioned this. In 6 months, 31 abortion reporting forms were received. The Guttmacher data would lead us to expect anywhere from 55 to 70 of those forms in that same time period. But that's only the most surface level. The second thing is that the Guttmacher reports that there were 2 abortion clinics in the state of Wyoming as recently as 2017. And then I spent some time on the internet looking, and that search suggests that this number even is low, perhaps even half or less than half of the true number. And I want to make sure that the committee noted in my public comments that what's most alarming is that there seems to be a medicinal abortion provider. That would be a provider who's both using the RU 486 method of terminating the life of the child and then expelling with mifepristone, and also another type of medicinal abortion which simply administers Cytotec and that a live baby is expelled. And this abortion provider is from Orlando, Florida, and yet is advertising in the Casper area with no discernible Wyoming address. And so I just want to make sure that the committee is aware of that, so that the Department of Health can follow up and make sure that it is abiding by Wyoming regulations. But along that line, so just back to the point of simply how many abortion providers there are in the state, the summary doesn't indicate how many of the providers in the state actually submitted at least one form for the calendar year. And I think that'd be relevant information for evaluating the effectiveness of the Department of Health's oversight that's required by statute 35-6107. And then the third point that I wanted to make is that is reading the footnotes. Very interesting. The Guttmacher report under Table 3 states that the criterion for distinguishing between the physician's office, that's a quote unquote, and a clinic is that physicians' offices reporting 400 or more abortions per year are classified as clinics. And then there's another footnote on page 18, specifically referring to Wyoming. And it says that in 2014 and 2017, there was one physician's office that was reported, and that their report has been updated to now classify that as a clinic. So that would suggest that the actual number of abortions in Wyoming possibly could exceed 800. That would be 400 from each clinic, unless the Guttmacher report is containing some kind of an internal inconsistency. And that would make the discrepancy between the actual abortions in Wyoming and those that are reported, it would change it by an entire order of magnitude. Instead of being, half of what's actually happening, now we're down to about 7%. And so once again, this raises the question relevant to your work as a committee, to make sure that the Department of Health is adequately enforcing Wyoming statute. And so I would simply encourage the committee to seek satisfactory answers to these 3 questions. Thank you for your time, and I stand for questions.
Great. Questions for Pastor Jonathan? Representative Yin.
Thank you, Madam Co-Chairman. Pastor Jonathan, so I went to take, so I did read your written testimony when it was submitted, and I went to check out this website, and I also couldn't find an address. So my thought is, how does one, as a person seeking an abortion provider, find an abortion provider that has no address? So my concern is, given this website is only Florida clinics, I don't understand how there could be an abortion provider that is trying to stay hidden, but then also providing abortion somehow. So if you could let me know if you found actual like physical advertisements in a newspaper where they were advertising, or what more than just a website that says Casper, Wyoming on it. Because as far as I know, that seems to be only a Florida service. And then secondly, my second question is, I did look at the Guttmacher report, the full report, not just the tables, and the way that they defined physician's office and clinics. If a clinic has clinic in the name, it calls them clinics. If a physician office is called a physician's office, but then also has more than 400 abortions, they also categorize it as clinics, as far as I'm aware and how I am interpreting that data. So because they reclassified as a clinic was because that clinic advertises themselves as a clinic, not because they provide more than 400 abortions. As far as I'm aware, I don't think that provider provides that many, given our population in the area is not large enough. And if we had that many, it would certainly be newsworthy, I would say that.
Pastor Jonathan, do you have any information about the advertising of the provider?
Yes. So I think you're absolutely correct that that without a physical location, somebody is not going to be able to make an office visit. And this gives me the opportunity to say that the Orlando clinic is not the only out-of-state clinic that has an online presence in Wyoming. There's also one out of the Omaha area. So I would simply say that the answer to your question is that a woman seeking an abortion from one of these places would access the telephone number and available on the website, because what these are primarily offering is a mail order RU486 abortion. So presumably either the prescription would come from Florida, for instance, and then would be fulfilled at a pharmacy in Wyoming, or the drugs themselves would come from Florida. With regard to the in-office later term abortion, I don't know. I don't have an answer to that. I just know that they're offering it, and I guess I assume that that the patient is invited to contact the telephone number at which further instructions will be given.
More questions for Pastor Lang? I don't see any others. Because I'm trying to do the Zoom committee and the handouts and the list of testifiers all at the same time, I don't necessarily have everything up. Did you send out the Guttmacher PDF? Is it from you, or is it being routed through LSO? Maybe LSO, you can pitch in on that. I'm just not finding it right away.
I got the information on how to route through LSO too late in the day to do that, and so I sent it to each personal email address.
I'm not sure I have it yet. Would you send it to me again, just because I'm not sure that I have it in the inbox? The other thing, and we'll have actually Mr. Bonenblust is up next, but if you could also maybe you've got screen captures or something of these advertisements for the out-of-state providers. I do feel that in general that that's something that we have dealt with as far as telehealth or licensing. You know, in Wyoming, to my recollection, we require physicians to be licensed in the state in which the patient is located. You know, and so obviously there's whether people are providing out of state eye surgery or out of state medication prescriptions. It's pretty difficult to follow up on a patient who's 800 miles away from you. So I mean, I have a little concern with that. If you could just send that to me and I'll ask Mr. Bonenblust about that next.
I will
Okay.
send both of those.
Great, thank you. No more questions for Pastor Lang. Okay, then I think we have up next, actually, Mr. Bonenblust. I'm not sure if he was meaning to testify, but I'm going to ask him a question. Are you here, Mr. Bonenblust? There he is.
I am, Madam Chairman.
Mr. Bonenblust, do
Yes,
you have
ma'am.
anything independently that you want to say before I ask you the question about out-of-state providers?
No, but I will apologize in advance. If it sounds noisy, it's because our roof is being replaced today. So timing is everything in life.
That's
So
right. Get it done while it's warm. That's really important.
and the wind is fairly low. Yes. I don't have anything in particular. I wanted to be here to answer any questions. So if you have a
Okay.
question for me, please, by all means, share it with me. I'd be glad to respond.
Okay, I am going to follow up with you probably on information about out-of-state providers advertising medical services for in-state patients whom they have not actually seen. I believe that that's again not authorized by the Board of Medicine. Is that correct?
Madam Co-Chairman, it's pretty much the nationwide that a jurisdiction holds that the practice of medicine takes place at the location of the patient. So it doesn't matter whether the physician is in Wyoming or outside of Wyoming. If the patient is located in Wyoming, then they need to be licensed in Wyoming. So in this case, if a physician's identified, we can take a look and they're not licensed in Wyoming. If they are licensed, first off, we have jurisdiction over them. We can, make sure that they are complying with Wyoming law. If on the other hand, they're not licensed in Wyoming, at that point, our jurisdiction runs out and it becomes a case for either a district attorney or county attorney to seek to prosecute for unlicensed practice in the state of Wyoming, which is a D misdemeanor, which is not exactly a big barking dog. But that's the alternative if they're not licensed. Now, if they are licensed, then we can also look at it and say, are you meeting the standard of care by providing this service this way? And that would be, an important question to ask. So.
Do you know, Mr. Bonenblust, I think I read that during COVID, the FDA, or I'm not sure who it was, rescinded the requirements that the abortion medications not be prescribed without seeing the patient. Do you know anything about that?
Madam Chairman, I do not. I do not know anything about that. I'm sorry.
Okay. All right, questions for Mr. Bonenblust? Okay, then we have Dr. McGill, and I hope he's still here, poor fellow. He's been waiting probably a long time. Dr. McGill, are you still here? LSO, did he give up and go away?
Ma'am, he is here.
Oh, good. Let him in.
I believe he's muted.
I don't see a square for him.
I am here.
Oh, there you are. Dr. McGill, welcome to the Labor Committee. You're on.
Thank you, Madam Chairman and members of the committee. Well, Madam Chairman, I think you significantly diluted the muddy water on part of what I was going to address. I am an OBGYN fellow of the American Academy of OBGYN, diplomate of the American Board of OBGYN and licensed in Wyoming. And a big part of what I was going to talk to you about was the importance of credibility in medical reporting. And there were two issues that I was going to bring up. And one I think you've somewhat cleared up is the involuntary termination, which would definitely cast some credibility issues on the report. I think I read it both as involuntary termination and later in the report as induced abortions, but I could be wrong. For the sake of the committee, if I may, I would like to provide a little bit of information and clarify a couple of things. Medical abortions are divided into two distinctively different categories. First is the spontaneous abortion, which you spoke of. Spontaneous abortion is the correct medical term for what is used in the laity, if you would, as a miscarriage. I would just suggest that the term medically induced miscarriages is somewhat of a misnomer. It would be a medically induced abortion, period, not a miscarriage. Spontaneous abortions occur in 15 to 20% of the known pregnancies, and it's part of the natural process. The second category of pregnancy termination is, of course, an elective abortion, or referred to as an induced abortion. And elective abortions are I was going to say, somewhat involuntary from the fetus's perspective, but not involuntary for any other perspective. But elective abortions are divided into two categories. That's surgical abortion, which is generally the dilatation of the cervix and the suction and sharp curetting of the contents of the uterus, and medical abortions. Medical abortions are again divided into two categories. Chemical abortions, which is the injection of chemicals into the amniotic cavity, which ultimately kills the embryo and causes it to be expelled, or medication abortion, which is the use of medications to cause the uterus to expel its conception. The term, if it's still there, involuntary abortion, could easily cause people to believe that we were talking about a spontaneous abortion. But beyond that point, the 2019 summary on abortion reporting stated that all patients received, and I quote, all patients received the early medical abortion procedure, parentheses, a non-surgical abortion. Now, this may be technically correct, but the statement is both non-precise and extremely confusing. The term procedure would imply that you were actually using a chemical form of abortion. In other words, injecting medication into the amniotic sac, because handing a prescription to a patient or picking up the telephone and talking to her and calling in a prescription for medication is not a procedure under anybody's classification. All of these agents, the chemical type of abortion is a very violent death for the embryo, and a very violent, and one of the more dangerous types of abortion to perform, the most dangerous type of abortion to perform on a pregnant woman. So on pregnant women. From the medical perspective, the agency really should make a concerted effort to avoid the use of confusing terminology. Words matter, and particularly in healthcare, words more than matter. They are crucial to be able to express a very definite point and pass that on in communication, either to other physicians or to the patients. So that in healthcare, words must carry a very precise meaning. If a report is to be credible, then it should be rewritten. If involuntary abortion exists in there, it should be taken out. And if the term medical abortion procedure, where they seem to have to define it then in parentheses as a non-surgical abortion, that needs to be clarified as well. Thank you very much.
Thank you, Dr. McGill. Any questions for the doctor? I do have one, seeing as you're here. It wasn't perhaps part of our original concept, but I presume you heard the discussion that there are potentially out-of-state providers of medication abortions. Setting aside the licensing issue, from a medical perspective, would you have any concerns about, and because I'm not that familiar with the medications, you know, the ability of a physician to provide care to a woman to whom he has prescribed a medication abortion if he's not in the same location? Could you just talk us through that a little bit?
I personally would have a lot of problem with that. I think it's entirely inappropriate, except under very specific circumstances, potentially to prescribe medication to a patient without seeing her. Now, I realize through Zoom, you can see a patient, you can do a lot through telemedicine, but if they're just calling for a to obtain medications for abortion, that's very difficult to do without being able to actually examine the patient, which is not quite possible on a Zoom call. You need to know what the age of the pregnancy is. You're not going to be able to determine that just because a woman gives you her last menstrual period, because a significant number of times that's off. So you don't know what age you're dealing with without looking at some laboratory studies, without doing an exam on the size of the uterus. So I think that would be a very dangerous thing to do, both for the patient and from a medical legal perspective as well.
Very good. Thank you. Any more
My
questions for Dr. McGill? Okay, thanks very much.
Thank you for the opportunity.
Representative Clem, are you still here?
I am. I've been kind of in and out. Thank you, Madam Chairman.
So I'm just going to let you clean up a little bit if you want to, because this was your bill originally. And then I'll ask the committee to pitch in. Or do we? And we obviously are not going to get any draft done today. I mean, you know, this is our last meeting of the year, so probably there need to be individual bills. But Representative Clem, did you hear anything that you felt needed cleanup?
You know, Madam Chairman, and not enough to speak intelligently on. I've kind of been in and out of the conversation, listening to it. So appreciate the testimony that was given. I did hear the last part of it really, really well. So, but no, I don't have anything further right now.
Okay. Any other committee members? Okay, I did see, and I haven't had a chance to look at it yet, that either the link or the form has shown up in our inbox as far as the form. I think just on our own, we're going to look at the form and look at the bill, make sure that we're getting the information that we wanted, which, you know, part of the discussion was, you know, we have family planning funding that goes to areas. We want to make sure that we're aiming it. Do we have information that is sufficient? I'm a little bit questioning, you know, just our procedure about only getting the form in from the people that send it. But there, you know, I'm going to follow up a little bit on the out-of-state issue. No other comments on that one? Okay, very good. Thanks very much. Our next topic then, only an hour and 15 minutes behind. is consideration of 21 LSO 222 statewide health information exchange codification. We had that bill pretty much laid before us in an undrafted form last time. And I imagine, let's see, LSO, are you going to present that, or? That looks like a bill. I'm going to make it larger. I'm down to 25% magnification. That's very small. Okay, Mr. Brody, are you going to tell us about this bill?
Madam Chairman, I certainly can. As you commented, this language is in large part a reflection of what the Department of Health had provided us. So I don't know, depending on your preference, if they're in a better position to explain the bill, but I'm certainly prepared.
You know, Mr. Brody, why don't you just zoom through, you know, committee, we did hear this last, gee, Mr. Brody, it seems to be longer than what the department gave us.
Well, LSO has some, you know, technical things that need
always that way, LSO, really. Everything I send you turns longer. I don't know, that must have some explanation for why our committee is always longer. I can't understand it. Okay, just run it through it, and then we can take questions.
Okay, I'll just go over the broad strokes. Essentially what this bill does is it codifies the health exchange that the Department of Health already has in existence as the result of a footnote that appropriated money to the Department of Health to create the health information exchange. That footnote was part of the 2016 budget. And as the committee will recall, the Department of Health came to the committee at its last meeting, said that the health information exchange had essentially matured to the point where it was probably appropriate for the creation of the exchange, the administration of the exchange, to be codified in statute and formalized. So that's what this bill does. The other notable thing that the bill does is it creates a fee structure whereby the Department of Health can impose a fee on providers to take part in the health information exchange so that it can operate and continue to provide the services of sharing the appropriate data. Really, the only thing that is in addition to what the Department of Health provided us is that we did put in a rulemaking provision just in case the Department of Health needed to implement additional administrative rules. They already do have some administrative rules in place for this health exchange, but just as a belt and suspenders provision, we did include that. And then Section 3 is just a split effective date to allow the Department of Health to go forward with rulemaking in order for this bill to become active on July 1st of next year. So I can stand for any questions, but that's the broad strokes for the bill.
Okay, and then I'll ask the agency if they want to add to that. But is there anything up front for Mr. Brody? Okay, Department of Health. I don't know who we got. Franz, Steph. Oh, it's Jesse. It must be Jesse. Mr. Springer, do you want to add anything to this?
We've reviewed the language of the bill, and we thought it was a well-written bill. We didn't have any changes or content.
Okay. Any questions for Mr. Springer? Chairman Scott. Co-Chairman Scott.
Madam Chairman, I want to pose two questions. I'd like to have Mr. Springer comment on them, but one of them, Madam Chairman, is a question as much for you as anybody. One is a question, and I hope that anybody else who talked to this bill will comment on. The first item is that when you look at what we're doing here, at the bottom of page 2, top of page 3, we're essentially creating, I call it an enterprise account, but we're using the funding that's coming in from the fees to fund the account. And that makes a lot of sense to me in this case, Madam Chairman. The question is, those of you who have more experience with the Appropriations Committee, including both you and the department, is that going to wave a red flag at the Appropriations Committee that will cause trouble? Do we need to have the money eventually go into the general fund to
to prevent that, or is they going to say, okay, this is pretty straightforward and we won't have a problem with it? That's the first question. Second one, Madam Chairman, the concern you hear from a lot of people in this area is related to privacy. And frankly, I think we now have a good set of privacy laws, particularly the federal HIPAA laws have now stood the test of time and really appear to work pretty well. Do we need to, this will obviously have to comply with those laws. Would it be productive to add a new subparagraph B, just a single sentence that would say they've got to comply with all the relevant federal laws in operating this health information exchange? Or is that just unnecessary verbiage and likely to get us in trouble on the floor? And I'd like the thoughts of the department on that, and I'd like the committee to think about that, because that is a potential issue with this bill. So those two general questions, Madam Chairman, and particularly I'd be interested in both the department's opinion and your opinion on dealing with the appropriations committee, the way this fund is to fund the program is structured.
Mr. Springer.
Madam Chairman, Senator Scott, it's pretty common for the Department of Health to have special revenue accounts. We have it for our state facilities. We have it for other revenue generating activities like the lab. I believe Vital Statistics may have a special revenue account, but there's a decent amount of special revenue accounts. And they're generally used when we're generating revenue from the user of the service so that we can use it to fund the service. And in this case, we're also seeking possibly grants and donations from, and essentially the fee structure is somewhat of a donation since it is voluntary from the hospitals and the physicians and things like that. So that's why we sought the special revenue account, because we thought that there would be less willingness to contribute if it got swept every year or 2 years as part of general funding versus being used for the purpose they donated it for or contributed for. And on the privacy question, Madam Chairman and Senator Scott, I think that we are subject to those privacy laws and to state privacy laws as well. And so we wouldn't have an opinion whether adding them or not adding them would add anything to the bill. We're subject to them, and we're subject to a whole host of laws and regulations that are quite extensive on this.
Mr. Co-Chair, I could see adding something, maybe even just at the end of paragraph A, I guess, because it certainly would just be stating what already exists. So I would almost say, leave that unstated now, and if it makes some people happier on the floor to stick it in, that'll be that'll maybe we'll save it for there. And as far as the fees, I believe Mr. Springer is correct about the fees. If Mr. Springer, I assume that this will this have a fiscal note?
Madam Chairman, we will prepare a fiscal note on this.
Right. So if it has if it has a fiscal note, it'll probably get re-referred. And if JAC feels the inclination to fiddle with it, it'll be hard to stop them. It probably won't be the end of the world, but so I guess I would recommend leaving it unamended at present and see if we can manage to not monkey it up. Just my thoughts. Any more questions for Mr. Springer? I think I did see someone's hand. Representative Syvar.
Yes, in section 2, where it says the rules may adopt, the department may adopt rules necessary. I'd like to see an amendment in there approved before it goes into effect, approved by this committee.
So they have rules already, and certainly the rules actually all the rules, I think, kind of wave past us in a vague sort of way. Chairman Scott, and you have more longevity on those issues.
Madam Chairman, on the question of having the committee approve the rules, you have a fundamental issue of the legislative versus the executive roles. The legislature has developed a complicated process through the Management Council where we review rules and make suggestions, but we cannot constitutionally put in a provision for a committee as opposed to the whole legislature to have to approve a rule. And if the legislature has to do something about a rule, it's not an approval or disapproval, it's we've got to pass a bill. So I would strongly urge us to avoid that. That'll get us in trouble, and we'll have to change it on the floor and could jeopardize the bill. This issue has been dealt with many times over the years, and at least with our Constitution in Wyoming, we can't do that. Frankly, I think, Madam Chairman, your advice on the other issue I raised is good. Let's just hold that in reserve in case we do have trouble with it on the floor. And people aren't satisfied with the explanation that we got to comply with those anyhow, and they work.
Okay, any more questions for Mr. Springer? Representative Sweeney.
Thank you, Madam Chairman. My only question with the budget cuts is this even going to continue, or will this be one of the future cuts? And I know maybe Jesse knows the answer, Franz.
I don't think there's any general fund money in this at all anyway. I think it's entirely fee supported, but Mr. Springer, do you have discussion on that?
Madam Chairman, Representative Sweeney, this is not currently planned as a round two, using the terminology. I think that we're actually on to round two now, and this would be, it's not planned as a round 2 or 3 cut at this time. It is primarily federal funds at this point, and what this statute is trying to accomplish is actually to reduce and offset some of the general funds that are used. So there is a general fund match currently used to receive the 90% federal funds. And when we go into operations and maintenance, this it changes the master rates somewhat, and but there is still significant federal funds available here. States made a huge investment in this system in time and providers' time, and that wouldn't be something that I think we would suggest eliminating. It's just would be really hard to rebuild. That would be the second attempt to do a statewide health information exchange. And I think if there was a third attempt some point in the future, then providers likely would not be very enthusiastic about it.
It's been operational already for what, about 4 years?
About 2, well, yeah, about 3 years, 2 years with providers, Madam Chair.
Representative Barlow, does I see your hand?
Thank you, Madam Chairman. So I guess I have a question on that point for Mr. Springer, 2 points actually. The first one is the way the bill is drafted is to recoup the department's costs for administrating. So I would hope we're not going to use the fees to supplant both the federal and the state general fund dollars, so that this language would say basically the fees have to cover the entire operation, when it sounds like we're actually dependent on some federal dollars. So maybe we should have a discussion about clarifying that component of the language about the department's costs, and maybe it should be general fund associated costs or something like that. The second question, I think, Madam Chairman, I'll wait and ask it for Mr. Brody. Thank you, Madam Chairman. So any comments on that cost issue and the current makeup, federal versus state component, would be helpful to clarify. Thank you.
Mr. Springer.
Madam Chairman, Representative Barlow, I think we assumed we would only use it to offset the general fund as written. So we're allowed to use any collected revenue as our match, as our state match for this. So whether it's provider contributions, which you see in some other Medicaid and other programs that we're using a provider contribution as the general fund match, or this type of funding. So I think you could clarify it to that end, but I think that's how we would generally use it. We're going to try to maximize the federal funds to the greatest extent possible, and then fill in the gap with revenues.
Okay, any more questions for Mr. Springer? Chairman Scott.
Madam Chairman, just to see if I understood the testimony properly, would it be a safe summary as we try to sell this to the rest of the legislature to say that what's going on here, we're providing a service that seems to be valuable to the healthcare institutions in the state, and we think they're willing to pay something for it, that what we're trying to do with this bill is that the federal funds require a match, and the purpose of this bill is, to the extent possible, to replace the current general funds, which are used as a match, with these fees. So the fees are intended to match the federal money. Is that a correct statement of what's really going on here?
Mr. Springer.
Madam Chairman, Senator Scott, I think that is accurate as of this time. Those federal funds are declining over time, but also our expenditures are declining over time because we had a lot of startup costs for this, and then we're moving into operations and maintenance. But what we're trying to do here, there is a certain amount of general funds already expended for this, and we're just trying to find other possible sources for that, which would be, I think, provider. Right now, this would be general fund, and if you had revenue from the facilities, and we have about 1,500 individual users at this point, and that should be probably 2,000 by the end of the year. If they were all making some sort of contribution, then it would help offset those general funds.
If I may, I see there are a few more hands, but I was just going to say, adding on to Chairman Scott's comment, yes, it would certainly be very nice of us to organize something for the benefit of all the providers, but it's not just that, but this assists with reducing the cost of healthcare, in the sense that if providers, including Medicaid, who is a state-funded provider, has to spend less money ordering more copies of the same test or x-ray that the patient has already had, that's a significant savings of pain in the butt and cost. That's an important thing for this, not just how convenient it is for providers. So,
Madam Chairman.
Co-Chairman Scott.
Madam Chairman, pain in the wallet, not pain in the butt.
Oh, I don't know. I worked in medical records for a while. Representative Clem.
Yeah, thank you, Madam Chairman. I just want to make sure I know what I'm about to vote on. Is this the same state health information exchange that we discussed at our last meeting about a month ago, that I know had some of our providers concerned? And I just want to make sure, number one, that that's the information exchange that we're talking about. And if it is, I also, my understanding is that is an opt-out system. And so I just want to clarify those two things. Thank you.
Representative Clem, this is the bill that we voted to have be drafted last time, and it is the procedure for which there is an opt-out feature, and we did see from the department some of the way how it is that a person opts out. Mr. Springer, do you want to add to that any?
Chairman Wilson, Representative Clem, I think that we presented those opt-outs. We have direct opt-out, and then generally a person can opt out with their medical provider. And if they opt out with any medical provider, they're opting out of this system completely. And we just keep a small person record that lets us know they've opted out, and then we remove their data from sharing.
Representative Clem.
Thank you, Madam Chairman. And just to be clear, that opt-out provision is by rule, if I'm not mistaken. Is that correct?
Mr. Springer.
Madam Chairman, that Representative Clem, that opt-out is by rule.
Thank you for that, and I appreciate the clarification and your indulgence with me. I will probably be bringing an amendment to this bill that makes this an opt-in program. So just be aware of that there, Madam Chairman. Thank you.
And just, I hear you. Contemplate as part of your amendment, are we going to require all the however many thousands of people who are already in the system to actually have to fill out a paper to now opt in, or are they grandfathered? Just to save, you know, every time you go to the doctor's office, you get some other piece of paper. And so I would, if every place they have to, I mean, I'm just consider the existing people. Okay, more questions for Mr. Springer. Okay. LSO, do we have any public comment on this bill?
Madam Chairman, we do have public comment, I believe. And then I would also just raise the issue of Representative Barlow said he did have a question for LSO.
Oh, yes. Well, let's let him ask that first.
Bill is relevant or not.
Representative Barlow, what was your question for LSO?
Thank you, Madam Chairman. Certainly my question is relevant, Mr. Brody. So thank you, Madam Chairman. So my question is, Section 1 of the bill A talks about the authorization, the codification of something that happened in 2016, Section 48, obviously the budget bill. And I guess I would like, at least offline, if Mr. Brody could actually point me to where in the budget bill this is actually, they believe this authority is coming from, because I just want to know where it is, because I want to read the exact language, and I'm looking at it, and it's a little tenuous for me to draw the conclusion where it's coming from. Thank you, Madam Chairman.
Do you have that handy, Mr. Brody?
Madam Chairman, I do. So if you look at the 2016 budget bill under Section 48, which is page 17 of the bill, you look at footnote 2. It talks about funds that were going to revert to the general fund under Section 303 and reappropriates that money to the Department of Health for the build out of a multi-payer statewide health information exchange. And it appropriated $1 million of that money that was going to revert for that purpose. And I'm more than happy to email that out, Representative Barlow, if you would like.
Representative Barlow?
Thank you, Madam Chairman. I guess the multi-claims payer database, as you know, was another discussion that we had. And so I guess I'm finding this to be a little bit confusing in my mind. So that's what I was trying to understand as I was doing this, is reading the reference in this statute. So I'll continue to look at it. Thank you, Madam Chairman.
Mr. Brody, because I have got too many things on my screen, could you just reread that footnote again, please?
Yeah, Madam Chairman, and if I misspoke, I apologize. The footnote 2 from the budget bill in 2016 authorized money for the state match for a build out of a multi-payer statewide health information exchange. So if I said multi-claims database, I apologize.
So the oddness is that there's the word multi-payer health information exchange. But that, to my recollection, that was not the multi-payer claims database, Representative Barlow. That was a different thing. You know, how that, I'm not sure that multi-payer has much to do with the content of the footnote, but I see what you're saying. But okay, Mr. Brody.
Yeah, I would just point out that on the next page of that bill, footnote 4 speaks to the multi-payer claims database that was also required under the legislation. So it does have both of those provisions included.
Representative Barlow.
Thank you, Madam Chairman. And actually, it is the multi-claims issue that I'm trying to sort out, whether that even needs to be a part of it, and whether when we're talking about recodifying something that's in statute that may not be clear, maybe we should actually say what we're trying to do in the bill, instead of just saying we're codifying something that, I mean, when I look at it, it's not that clear what we're codifying. So I just throw that out, and maybe we should actually also codify what the purpose of it is, if we believe that it is a meaningful program. So thank you, Madam Chairman.
Yeah, well, it does say in that paragraph, authorized to administer and maintain the exchange to facilitate the secure sharing of electronic health information between healthcare providers for the benefit of Wyoming residents. Are you thinking that needs to be fleshed out farther? Not now. Okay. Poor Jesse Springer, he's given up. No, he's back. I didn't mean to scare you off. Okay. All right, LSO, let's let in our public commenters. I believe
we'll let them in. I apologize, ma'am. Andy Somerville has let us know that she does not have comments at this time, but we will let Wyoming Hospital Association and Miss Kieran with Blue Cross Blue Shield in.
All right, we'll send them in. Well, I see a bison who I take to be Josh Hannes.
Hospital Association and Miss Kieran with Blue Cross Blue Shield.
All right, we'll send them in. Oh, somebody has their YouTube running. Could you turn that off, please? Josh, is that you?
Yes, I'm here, Madam Chairman.
You've shaved or something.
I have.
You don't look like yourself. I hardly recognize you. Okay, go ahead, Josh. Welcome to the Labor Committee.
Thank you so much. Madam Chairman, members of the committee, my name is Josh Hannes with the Wyoming Hospital Association. I'll keep my comments very brief. We are here to support this legislation as drafted. There's really a couple issues included in here that we care about and when we think they're addressed in the language here. So one, for the department to be able to establish fees and collect those fees. And then two, making sure that those fees are protected and solely used for the purpose of maintaining the health information exchange. Our hospitals find it to be a useful tool for communicating, coordinating care. Right now we have, I think it's about 20 hospitals that are either fully connected or in the process of being connected. So we're supportive of this program moving forward and what this bill does to protect and enhance what we currently have. And we anticipate more of our members joining on. So we certainly stand in support and encourage you to move this forward. And I'll stand for any questions.
Questions for Mr. Hannes? Okay, great, thanks. Ms. Curran. Ms. Curran, you're muted.
I know. Madam Chairman.
Welcome, Ms. Curran.
Madam Chairman, members of the committee, I'm Wendy Curran. I'm with Blue Cross Blue Shield of Wyoming. I think that perhaps Representative Barlow has pointed out some of what we would ask about today. We're very supportive of the effort to have a health information exchange to help lower healthcare costs. However, this particular program has been confusing for us from the beginning. As you just referenced, it calls for a multi-payer health information exchange, which implies that payers like Blue Cross Blue Shield could participate, might want to participate. We're not sure if it's voluntary. And I think that as it goes forward, those would be simply our concerns. There has never been a statute that has clearly laid out those provisions. How would a payer participate? Will they be required to? If there is claims information from different payers, what does that? I'm not paying, not claims information, but health information. So we encourage this to go forward. We just think that some of those discussions about confidentiality and payer and clarifying some of it certainly could be something that goes along while we're discussing it.
Questions for Ms. Curran? Jesse, I want to follow back then to you. From my just hearing of that footnote, I hypothesize that probably that multi-payer line was just an extraneous drafting glitch that rolled in from some other footnote out of confusion. I would hypothesize. Are there insurers at all involved in this system now?
Not, Madam Chairman,
I'm
not
sorry,
to my knowledge.
I was asking Mr. Springer.
Oh.
Mr. Springer?
Madam Chairman, currently the only insurer that would be participating would be Medicaid. And the type of data we would be adding that wouldn't be coming directly from a provider would be pharmacy data from our pharmacy benefit manager, so that we can get a more comprehensive view of care. I think it's a good observation that all participation of all entities is voluntary. And yeah, I think you could explicitly put that in statute if that would, I think, clarify. There's no requirement in rule or in was ever indicated that this would be mandatory for any payer or for any provider. It really is, it needs to be valuable to the people participating, and they should choose to participate.
Chairman Scott.
Madam Chairman, I guess really a question for Mr. Springer. Would it be, and I guess for Mrs. Kern as well, would it be helpful on page 2 if we referred to this as a multi-provider database? Because that's what it seems to be.
Mr. Chairman?
Oh, Ms. Curran?
Madam Chairman, Senator Scott, I think that would be appropriate. Just any sort of clarification. This is a program of some magnitude and some importance to the state and the healthcare system, but it isn't backed up by the kind of statutory provisions that we usually see. It's by rule and reg completely within the Department of Health. So any language that helps clarify the background, I think, would be beneficial.
Madam Chairman, I think it would be helpful. Really, it's a health information exchange. The extra descriptive words preceding health information exchange. Health information exchange is a industry term. It does have meaning. I don't know if the extra words preceding it really add anything, whether it's multi-provider or multi-payer. There could be payers that participate. We haven't explored that with other insurers in the state at this point, because our focus over the next few years is going to be providers, because the value is primarily providers. But it could be that we ask insurers to do what Medicaid is doing, which is contribute possibly their pharmacy information. We haven't explored that. It's not something we've got into, but our focus really is hospitals, large clinics, making sure that and then physicians, and then we have other users that are using it to coordinate care. But that's been really of our focus is providers, because it's a provider to provider exchange. But there are extra sources of data which we are adding, which include public health databases like the immunization registry, so that if somebody goes 3 or 4 places for immunizations, and a child shows up in your office, which immunizations they've had without checking 3 or 4 databases. So there are public health databases that we are connecting to as well, that help the provider from having to go to 3 or 4 places, or even having to leave their EHR. That's the goal, is they should be able to be in their work stream, and the supplementary data from other providers is there, so they don't need to go get faxes off the fax machine, log into 4 websites, or by default just order tests, because that's easier than trying to get them from another provider.
It does seem to me that on line 7, where it says healthcare provider, I mean, that's, to my mind, an insurer is not a provider. Okay, a pharmacist is a provider, but an insurer is not. So I feel like that's stated there. If we wanted to say on line 6, facilitate the secure and voluntary sharing, that maybe that would clarify that no one's going to be roped in against their will. But any more questions for Ms. Curran? Chairman Scott.
Madam Chairman, for Ms. Curran and Mr. Springer, if we were to add on page 2, line 4, a sentence, the term quotes, multi-payer quotes, in the footnote shall be regarded as irrelevant, would that help clarify because it seems to have caused some confusion.
Madam Chairman, Senator
Ms.
Scott.
Curran?
Thank you. I think that would work. I think the confusion has been two things: the multi-payer, the is it or is it not voluntary? Is there a point at time in which we would be asked to participate in pay? I mean, I think it is voluntary at some point. That will be beneficial for all of us. I think that, yes, the voluntary provision and the emphasis on the provider would be helpful in lessening that confusion.
Representative Clem.
Thank you, Madam Chairman. I have a question on page 2, and this is lines 10 through 12. So here we say the department may charge reasonable participation fees to participating entities subject to the following. And I'm just not sure what the definition of entities is. I am assuming that an entity isn't an individual Wyoming patient, right? We're not going to charge Wyoming patients to be a part of this, although I don't know that because it's not clear. I guess more concerning to me is as far as a participating entity. I don't know if that would be, someone like Blue Cross Blue Shield, or if it would be Wyoming Medicaid, or does that mean an individual doctor's office or a hospital who is in this system? So I guess I'm just confused. It just seems unclear to me, and so I'm wondering if does anybody else know what this means, or do we have to tighten up that language? Thank you, Madam Chairman.
Mr. Springer.
Madam Chairman, I think that language was suggested intentionally because there's a lot of different types of contributions that could occur. So I think as Representative Clem suggested, it primarily would be provider, hospital, physician would be the contributions. We also have other types of users that may use this. Other states, we haven't explored this use case, but other states are allowing the coroners to use this so that they can get the records they need more quickly for the death investigations. And then an entity might be an insurer if they choose to contribute. We haven't made the value proposition to other insurers at this point because we've been focused on building out our connections with providers. That I think is the value here. But I think it would benefit other insurers, including possibly Medicaid, employee group insurance, Blue Cross Blue Shield, other insurers in the state, to consider contributing to this in the future, because it's basically reducing duplicate expenses for the insurers.
Right, but the thing is, right now, as the bill stands, it says, and as you are doing in rule, the sharing of electronic health information between healthcare providers. So these are people who produce medical records. Individual people don't produce medical records. I mean, medical records are produced by healthcare providers, which are hospitals, clinics, physicians, physical therapists, pharmacists, and such like. So,
Madam Chairman, I think you could define instead of the word entities, you could use providers, Wi-Fi users, and possibly insurers if you wanted to go there. Or we could revisit that again at a future date if to add additional participating entities. And you could very clearly say that in no case would a patient be charged a fee. That's never been envisioned that we would charge any patient a fee for this. That's not, I don't think that's feasible, and it's not really the model.
Chairman Scott.
Madam Chairman, I would urge a little caution here. I think the broader term entities is a good idea. Suppose sometime in the future, there's a feature here where a patient could ask for their own vaccination records. That's something that, and be willing to pay a fee for that. That might make sense. And I don't want to preclude that as a potential future development, because it might be something that would be a real convenience to the patient. So I think keeping this pretty broad is a good idea.
Madam Chairman, Senator Scott, actually by law that there's some rules that have been promulgated, will be required to provide patients access to their data for free. And this will be one of the mechanisms possibly that providers use to comply with those sort of patient access rules that are coming in the next few years.
I think that's actually a new federal rule, isn't it?
It is, Madam Chairman.
Okay. So are there any more questions for Ms. Curran, which I guess is what we're technically still doing? Okay, very good. I think that's all the public comment we had. Then public comment is closed, unless of course we haul you back on, which you never know might happen here. Do I hear a motion on the bill? Moved by Chairman Scott. Is there a second? Seconded by Representative Roscoe. Is there any discussion? Chairman Scott.
Madam Chairman, I think this is something that is much needed. It is potentially cost savings. It looks like it's working well enough so that we think that the various healthcare providers would contribute. So I would urge us to proceed with it. And when you're ready, Madam Chairman, I have two amendments, one of which is the one you suggested a few moments ago.
Okay, well, I don't think we'll have anything on page 1 anyway, so let's turn to page 2 and go ahead and make your page 2 amendment.
Madam Chairman, first one is page 2, line 6. After the word secure, to add the words and voluntary.
Okay, is there a second? Seconded by Clem. Any discussion? Okay, all in favor of that amendment, please put your hand up in front of your face. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Okay, that's unanimous. That amendment passes. What was your second amendment?
Madam Chairman, page 2, line 4, after the section 048 period, add a new sentence. The term quotes multi-payer quotes in the footnote shall be regarded as irrelevant.
Is there a second? Seconded by Stivar. Any discussion? Representative Sweeney. Chairman Scott.
Madam Chairman, and I am having internet connection, so I may cut out. I'm having difficulty with that. But the purpose is that language in the footnote seems to have been an accidental import, caused people to think there's things there that aren't. The language in the bill, statewide health information exchange, is what we're really really talking about. But I think rather than going back and amending the footnote, I think just saying that that language doesn't count will clear up the problem that a number of us have had with that.
Mr. Brody, is that language, is that good statutory language, or might we need you to wordsmith that a little?
Madam Chair, LSO would ask for just a little bit of authority to massage that language a little bit more, to maybe make it consistent with other statutes where we may have similar provisions.
Would that be all right, Mr. Chairman Scott and co-chair, or second?
Madam Chairman, that's fine.
Second, Representative Clint, or no, it was Representative Stivar who seconded. Are you all right with that? Okay. Okay. Any further discussion on that amendment? Okay, if you're in favor of that amendment, please put your hand up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. I missed it, 14. Okay, very good. That passed then. Okay, any further amendments? Representative Clem.
Thank you, Madam Chairman. Let me pull up my screen again. This would be page 2 on line 11. After entities, insert comma, which does not include individual patients, comma.
So I'm writing that's okay. Is there a second?
Second.
Seconded by Chairman Scott. Any discussion? Mr. Brody, are you attempting to? Mr. Brody, you're muted.
Apologies, Madam Chairman. I guess I would just ask just a little bit of flexibility. Generally, we would use the directive of shall or shall not, or may not. So if we could just have a little bit of flexibility.
Is that all right, Representative Clem?
That would be fine. Thank you.
And Chairman Scott, is that okay with you? Okay. All right. Any further discussion on that amendment? All in favor, please raise your hand. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. I only see 13. Is there a no? Senator Baldwin votes no. Okay, that amendment has passed. Yeah, hang on. Sorry, I'm marking up my paper here. Okay, any more amendments? Representative Clem.
Thank you, Madam Chairman. This would be on actually page 3, line 6, inserting a new subsection C, which would state the following. Patient participation into this statewide healthcare exchange who are not currently enrolled as of June 30, 2021 shall be by opt-in only. And I can repeat that if you need me to.
LSO, did you get that language? Mr. Brody?
Madam Chair, if you could just repeat it once more, just belt and suspenders.
Sure.
Okay.
Again, it would read new subsection C, patient participation into this statewide healthcare exchange who are not currently enrolled as of June 30th, 2021 shall be by opt-in only.
Is there a second? Seconded by Stivar. Any discussion?
Madam Chairman, if I may explain the amendment here.
Sure.
So this is just, I see tremendous value in this statewide healthcare exchange. My only concern is just on the patient side of things, that a patient should willingly, of their own volition, be a part of this, that it shouldn't be something that they're opt into automatically and have no knowledge about. And that's the concern here. It's more of an informed consent provision, which I think could be handled by a simple form, because as we state later on in section 2 of the bill, that they're going to draft rules and regulations. And so it's written broad enough and in a general sense that I think the department could promulgate rules on how to handle this provision. I don't want to be overly prescriptive here. And it really does cover those who are currently enrolled. As we see here, the new rules, while the effective date for this bill would be it would be immediate, we say that the rules actually do not apply or do not go into effect until July 1st, 2021. And so that's the reason for the June 30th, 2021 language, is to grandfather those who are already in the system to remain that well. And so they don't have to hassle with anything, but going forward for new patients who would like to be a part of the statewide healthcare exchange, they do so volitionally of their own free will. So that's the explanation. Thank you, Madam Chair.
Thank you. So I have a question, and Mr. Springer, are you still there? So just on the operation of this, so and so that we could hear from Representative Clem what his thinking is too if this goes forward. But so operationally, would you anticipate that a patient would need to opt in with every provider? So for example, I have a primary care nurse practitioner. I've been to the orthopedic surgeon. I've been to the x-ray. I've been to the health fair for lab work. If I went to the ER, I mean, would your rules contemplate that at every different provider I would have to authorize opting in, or if I opt in once, am I opted in for everybody? So I guess I'll go back to ask Representative Clem, but let me just Mr. Springer, how would you hypothesize that, or how does that work elsewhere?
Madam Chairman, generally opt-in or opt-out is global. So you're either opting in to participate or you're opting out completely. We did provide some data on states that are opt-in versus opt-out in the previous presentation.
Right.
The system itself is built around the concept of opt-out, not opt-in. So it would need to be rebuilt. And so I think that the provider systems are built around opt-out. So I think it would be quite extensive change to the system as currently constituted.
As far as programming, you mean, or the form, or what?
Madam Chairman, it would be a change to the provider systems and to the state's health information exchange system. Both sets of systems are built around the opt-out concept. And it's the more common concept nationally, and many states that were opt-in have moved away from that model, mainly due to feasibility concerns. They just never could achieve scale.
And my recollection is when that the person is informed in some way that they are being put into this system when that the patient gets a form to either opt out or to opt out, let's just say now, right? I mean, are they basically consenting to their?
Madam Chairman, in the privacy policies, we work with each of the entities that's participating to make sure this is noted. So you get that stack of paper, and one of the items in that stack of paper is not describing the privacy policies regarding this. And then we have on the Department of Health website and on the Wi-Fi website direct opt-out provisions. So we are providing that information. I think it's going to be a continued effort on education of patients. There was, I think, some concern about this, but originating out of that concern, we had, maybe 40 to 50 callers, and of those, 15 people to date have opted out. So once our staff explained what the system was and what it actually did for them, a good number of those callers actually chose to continue participating. And then we have to date about 15 people that have actually completed the direct opt-out form.
Okay. Senator Bouchard, did I see your hand?
Thank you, Madam Chairman. I was actually going to talk about that. We had talked about this before, so we just discussed it now. So
we did talk about it last month, but okay. Is there any more discussion of this amendment? Senator Scott, you're muted still.
Madam Chairman, I would hope we could reject this amendment. It does, I think the system has already been built, opt out, and changing it, I think, would be probably quite expensive. I've been shocked in the past by how much it takes to do anything with a large computer system. It does illustrate a little bit the difficulty of legislating in the budget. You don't deal with these questions up front before you start building things. But that's water under the bridge. We passed the budget footnote, and here we are. I don't think it would serve much useful purpose. I don't think there's a great number of people that would be really, if they think about it carefully, wanting to opt out, and that's been our experience. So I think the opt-in will merely lead to a lot of confusion and paperwork and not really do much but run the cost up.
Representative Hallinan.
Thank you, Madam Chairman. My question for Mr. Springer is, are we already opted in, or do we have to opt out now? I mean, say I had an x-ray done, am I already opted into this program because my hospital is? Or do I have to opt in or opt out? I don't understand that. So what is your answer to that, Mr. Springer?
Mr. Springer.
Madam Chairman, the primary so when the providers have joined and they turned us on, they're sharing a certain set of data with us. There's protected data that we talked about, that's mental health and other things that we work with the providers to screen out of the data feed and the data exchange. But if you're going to one of the participating hospitals, for instance, and you have not completed an opt-out form and you have not spoken to that physician about marking the opt-out box in their EHR, in their electronic health record, then you are currently, your data, your healthcare data could be called by one of your other healthcare providers. They would need to know a good amount of information about you to pull this up. So you can't just go in there and say, I would like to look at Jesse Springer's data and not know anything about Jesse Springer. You have to have enough information about the person to actually pull up that person's records. And so it's a set of criteria. You can't just go in and say, I just want to look at Jesse Springer's data. But if your physician, maybe you're being referred over to, after surgery, to a physical therapist or your primary care physician or something, they would be able to interchange records. And some providers are using it for secure communications as well, for encrypted communications, where, previous to that, their default might have been a fax machine. I know fax machines are still quite common. And this is, I think, one of the solutions to the fax machine problem, among other things.
So to that, Representative Hallinan, I believe Campbell County Hospital has been a member for a while, or no, actually, maybe they're just joining this year, I think. And so if you have been seen this year, presumably your provider, amongst all the other HIPAA compliant forms and whatnot that you generally get when you check in, that would be when you would opt out or in. Representative Clem.
Yeah, thank you, Madam Chairman. So just to pile on here, Campbell County just recently joined. In fact, I just recently went and saw my primary physician, who's part of Campbell County Medical Group, which is associated with the hospital. I was not informed that I could opt out or anything like that. In fact, if I had no knowledge of this, I wouldn't have known any different. And yet my information is opted in. That concerns me because I think that as in our day and age where we value the protection of our privacy and we value the protection of our data, that this should be something that patients are aware of and something that if they want to volitionally give over that information, they should do so. I see great value in the system, but on the patient side of things, I value patient participation in the fact that it's voluntary and that privacy is respected, the wishes of those people. And quite frankly, there was nothing when I registered and saw my doctor, 3 weeks ago, that I had any information about this healthcare exchange, and that's concerning to me. As far as the amendment itself and the questions that you raised, Madam Chairman, again, the language is patient participation into this healthcare exchange, and so it's not targeting individual providers so that you would have to opt out with each individual provider, but it is the healthcare exchange itself. I would also add wherever, whether we have an opt-in or opt-out, the problems still remain the same. And that is this: if you see 3 healthcare providers, and I want to opt out, do I have to opt out with each and every one of those healthcare providers? Or is it just one of those healthcare providers and now I'm out of the system? And so I think those are logistical things that obviously rules and regulations can handle. And whether it's an opt-out or opt-in, I think it could be handled the same. So for instance, if I opt out with one provider, I shouldn't have to opt out of the system with all the other providers that I see. And so I think that's one of those logistical things, again, rules and regulations could handle if we make this an opt-in, that if you opt in, regardless of the provider, that you're opting into the healthcare exchange, and so you would be opted in from that point on. So I understand the argument from this is going to cost money and it's too expensive to do. I just don't think you can put a price on a person's privacy, and so I think this is valuable from that aspect, considering that in our day and age, and we talk about the privacy of people's data when it comes to Google and Facebook and social media and all these other things, what is even more valuable than some of those data pieces as far as privacy and concern? And I think our healthcare data is far above that. So that's the reason for this amendment, and I would urge an aye vote. Thank you.
Okay, so I think that's been good discussion, and we can probably go on from there. If you vote for the amendment, please put your hand up. 1, 2. I'm going to call you out just because the backgrounds are a little confusing. Okay, I see Stivar, Hallinan, Clem, Dayton, Selman. Is there anyone else? If there's anyone else, those wave wildly so that I can see your hand. Okay, 4. If you're opposed to the amendment, please raise your hand. Scott, Yin, Pappas, Bouchard, Sweeney, Schuler, Baldwin, Roscoe. Representative Barlow, I didn't see your vote. Anyway, 4-4. All right, that amendment fails. Are there any more amendments? Okay.
Question on the bill.
Question on the bill. Mr. Brody.
Madam Chairman, this is on whether the committee will sponsor 21 LSO 222 as amended for the 21 general session. Senator Baldwin.
Aye.
Senator Bouchard.
Aye.
Senator Pappas.
Aye.
Senator Schuler.
Aye.
Representative Barlow.
Madam Chairman, is this on the bill or on the amendment?
The bill.
Aye.
Representative Clem.
No.
Representative Dayton Selman.
Aye.
Representative Hallinan.
No.
Representative Roscoe.
Aye.
Representative Stibar.
No.
Representative Sweeney.
Aye.
Representative Yin.
Aye.
Co-chairman Senator Scott.
Aye.
Co-chairman Representative Wilson.
Aye.
The bill has passed.
Okay, committee, we have, it's 12 o'clock. We have our long-suffering social workers that were scheduled for 10:30. Chairman Scott, have you got any input?
Madam Chairman, I think we can dispose of this one pretty rapidly, given what I think we're going to hear.
Okay. Let's see. Potential consideration of draft legislation. So actually, so the public, we're on item number 4, certified social worker certification requirements, following on some discussion that we heard regarding rules. And Chairman Scott, I think if I can ask you to present, because I know you were going to do a little bit of work on that. We do have some public comments, but Chairman Scott, go ahead and tell us what you found.
Madam Chairman, if the committee will recall, we heard about this last time, and I volunteered to work on it, and Andy Somerville volunteered to help. And Madam Chairman, she's got members that were last time on both sides of this issue. And I think the proper way to handle it is to seek a reasonable compromise on the issue that everybody can live with. Madam Chairman, is that she's been developed the language, the appropriate place to put it would be the bill that we approved for introduction last time on the whole licensure in this area. It would be a germane amendment to that. And the last I heard, she had language developed and was trying to make sure that all the contending parties were in agreement with that. That may need some refinement, but the thinking is, and I hope Ms. Somerville will comment on that, but the thinking is that the thing to do is to bring it, work the controversy out and try to bring it as an amendment to that bill in the first committee during the legislature.
Okay, so committee, because we have, those of you who are listening in on this topic, and I'll try to time it so that you can follow where we're at. We heard previously that sometimes the YouTube lag makes it a little challenging for people to find where they're at. Actually, LSO, could you let in the people that wanted to comment on 4 so that they can all hear me talk at one time and we don't have a time lag?
Ma'am, I will do that. I will ask those individuals to stop their video unless they're testifying, just so that we don't have too many little squares up.
Okay, I just want them all to be able to hear at one time and not have them come in wondering what we just said. Okay, do we have everybody in from that? I think there's an old time hymn about that. Are all the children at home or something like that? So those of you who wanted to testify on item number 4, I am going to take the testimony. Chairman Scott did say, and so I'm actually going to call on Andy Somerville first, just to give her a heads up on this. There was an attempt to find some kind of compromise language. Senator Scott suggested that if there was language, the best time to deal with it would be in the mental health licensure bill that we've already agreed to sponsor. We can't amend that today because we didn't notice that bill. We've already voted for it as it is. So that would be something that we would do in committee during session if it turns out we can find appropriate language, although we may not. But because you're all here, I wanted you at least to be able to hear that. Hang on, I'm just looking for my pen. And so those of you who want to testify, given that there will be time again, probably, I mean, assuming that there is something that is worked out during session, I would ask you to just keep your remarks fairly condensed at this time, knowing that we are not actually going to be able to amend a bill today because of the requirements for noticing that we didn't do. So don't give us your whole 3-page history of social work in the Western Hemisphere yet or anything. Just kind of keep it so that we can get a sense of where we're aiming. So Andy, I'm going to ask you to go first, put you on the hot seat there. Just tell us what you think you discovered in working on this issue.
Thank you, Madam Chairman. I'll just start off by saying, as always, when digging into licensing things, the well is deep of information and things you can consider when doing these things. Madam Chairman, with your permission, I'd like to share a document on the screen just to highlight 2 quick things. You guys have all gotten it by email, but.
Yeah, go right ahead.
Okay. Okay, can everybody see that okay?
It's very small. Maybe it's just me. Can you see if you can, there, that seems better. That's good.
Good?
I think that's
Okay.
good, yep.
Perfect. So in trying to craft a compromise on this issue, one of the things that we discovered is there's a lot of confusion around the terms such as counseling here. And there's been some confusion and a lot of discussion, I believe, at the board level as well, in terms of trying to keep all these terms straight. It's important to recognize that although it's easy to compare across the spectrum, a CAP, which is an addictions professional, a bachelor level social worker, bachelor level mental health professional, and then the equivalent licenses, those professions don't always use the same language. And so one of the things in this potential compromise is clarifying some of that language. So I'm actually going to scroll down here to the bottom of this next page, if it catches up. Oh, come on. Okay, so first potential conversations that we've had is clarifying the definition in statute about a certified social worker. This definition, I won't go through it in detail, but it has components in it from the national level, a model practice act, and then some things that we do here in Wyoming at this level, like psychoeducation and education. But essentially better defining what a certified social worker can do in statute. And then the next piece of that is tweaking the definition for the practice of counseling, which is what we have right now, to change that to the practice of professional counseling. And what this really does is separates out the master's level from the bachelor's level in terms of providing psychotherapy. And that's an important distinction to make. And I think one that we have pretty good agreement on. And then potentially another way to help this along, in the Model Practice Act and in several other states, there's an additional definition. Some call it supportive counseling, some call it counseling techniques, but it's specific to that bachelor level of social workers and just speaks to the types of counseling. So individual, couples, families, groups, kind of defining that they're there in all of those ways that they can help assist and work a program after they've been diagnosed by a licensed professional. What I will say is where we do not have agreement yet is on the topic of diagnosis. And to keep my comments brief, Madam Chairman, what I'd ask the committee is, I think we've got a good start here. We'd like to continue those conversations and continue to work it before session so that we can come back to you guys at the beginning of session with an amendment that we've got agreement on from all the parties. Certainly the social workers have some conversations with the board members, as well as the different organizations that employ these CSWs. So with that, I'd stand for any questions, just to keep it brief today.
Very good. Questions for Ms. Somerville? And if you can take off the good, that way I can at least see most of the people. Questions for Ms. Representative Stibar.
Yes, to clarify, Ms. Somerville, the CSW test for a bachelor's level social worker and a master's level social worker are two different tests. Is that correct?
Ms. Somerville.
Madam Co-Chair, Representative Stibar, that is correct. They are two different tests, and currently we use the ASWB test. And I believe there might be an ASWB rep in the public comment hanging out somewhere.
Senator Schuler, did I see you?
Thank you, Madam Chair. Just I'm tickled that you guys are making some progress and that you've made, moving forward. It sounds to me like the diagnosis is the only issue. Could you maybe clarify that just a little bit?
Ms. Somerville.
Madam Chairman, Senator Schuler, I think diagnosis is the biggest sticking point that we have to work out. I think there's a little bit of additional dialogue about specifically what types of counseling and what terms we really need to put into statute to define that. We're a little bit unique in Wyoming in that our descriptions are pretty robust in statute, whereas compared to some other states, they're more general, and then the board sets those terms. So we still need to have some of those conversations about what needs to be in that definition specifically.
More questions for Ms. Somerville. Senator Bouchard.
Thank you, Madam Chairman. I'm looking at the notes or the summary sheet, and I'm really concerned here, because what I see here when there's just one little part in here that talks about addiction therapy, and I kind of feel like everything's been lumped in here. And now this makes me just even feel more strongly that we need to take addictions out of this whole thing. I mean, this is getting to where we're going to build more fences. And quite frankly, I'm not liking it. I mean, we've got people that convince me I'm wrong here.
Senator Bouchard, let me just clarify. So we're talking about the topic of certified social workers. I'm not sure. Are you thinking ahead to the mental health licensure bill that we passed, which we're not really? We're not considering that today. I'm confused a little bit.
Thank you, Madam Chair. I'm looking at the language that was sent over about the summary of everything. But no matter where we put it, if we put it in what we're suggesting now or in that previous bill that we've done, it seems like what I'm always seeing here is we're going to corral everything onto addictions in with social work, and it just doesn't seem like it. Seems like every time we take a little step forward, we take a step back. And so that's what I'm seeing here.
Okay, because I don't have all of that out here, I think the best thing to do there would be, when we have, so we've got the two bills going forward from committee, and then as we get the language in session, we can really lay out that and just make sure how that is fitting in. I mean, for me, it's a little difficult to, right now it's kind of in the cloud, and it's sort of hard to parse in, but I hear you. Well, session is coming, Senator Bouchard.
Madam Chair, I mean, I'm looking at it on the phone is where I have it. I'm looking at the
you're even cleverer than I to look at it on your phone.
So like I said, it concerns me because quite frankly, the people that and I'll just say it, WAMSAC represents an interest in an income that comes into their with their contracts, and there are other people that aren't necessarily at the table, and some of them don't have lobbyists, and some of them are smaller providers. Anyway, I'm concerned. I mean, we need to really start drilling down on addictions. This isn't rocket science in other states. We just keep moving down this road to build more fences, and that's my concern.
Okay, although right now we're dealing with social workers. Representative Sweeney.
Thank you, Madam Chairman. So my question is, my understanding is that these rules are at the governor's office, ready for signature. Have we had, and maybe this is to Andy, have we had any indication that the governor is willing to not sign, put that on hold so that more work can be done on this from that area, and possibly Chairman Scott has information that way?
Ms. Somerville?
Madam Chairman, Representative Sweeney. So I can only speak to the conversations that I've had with the governor's office on this. I have met with Jen Davis, the Human Services Policy Advisor, talked to her about the situation, let her know that there were discussions ongoing and that we were working on this. Those rules, I believe, do not have to be signed until later in December. So it was my intention after this meeting to report back to her and meet again with the group and all the individuals that I've met with that are interested in this, and then see where we need to go from there. It is a little bit of a difficult process to navigate with rule changes sitting out there and potentially taking changes to the legislature. But we wanted to work on this compromise, and if we can get that crafted, we can give that information to the governor's office and then potentially ask him not to sign the rules and wait for this legislative change.
More questions for Ms. Somerville? Okay, great. Thank you, Andy. I'm just going to go down the list now, folks. I guess you're in order of when you showed up or something like that. So I see Kara Sanner. Oh, Kara, you're muted. There you are. Nope, still muted. There you go. Welcome.
Yes, thank you. Good afternoon. Yes, I am Kara Sanner. I am with the Association of Social Work Boards. I provide regulatory support services for our member boards. You all may be aware that we are the membership association for the state and provincial social work regulatory authorities. We do develop and administer the social work licensing exams that are used in the US and Canada. We also provide a number of other services to our members with regard to the administration of professional regulation, and we have a wealth of information about professional regulation. Like this committee, we share a very important public mission, a mission of public protection. And I did provide a number of written materials, but given the I suppose the change in the scope of today's agenda, I will just try to really quickly kind of go through some comments and just acknowledge that you have the written materials. There's quite a bit of information there. I'm happy to follow up with you on any questions that you might have. Thank you. It's my pleasure to be here. I'm hoping to provide a national perspective that will hopefully assist the committee with its work. I know that there's some discussion with regard to CAP standards, and that is sort of muddying the waters to some extent, but I really do want to focus on the CSW regulations that were approved by the board, and then also by the committee last month. And then the first point I want to make is just that the clarifications that the board put forward regarding bachelor scope of practice are clearly consistent with the statutory intent in Wyoming law for certified social workers in the practice of clinical social work. Now, I understand that there's been some questions about whether or not certified social workers are qualified through their education and training to perform diagnosis and psychotherapy. That has kind of taken the committee into another area, and that certainly ties into the issue with the CAP standards. But I would just say, as the committee approved the bill, it is consistent with the intent of the statute. And to Ms. Somerville's comments, Wyoming is very specific in its statute with regard to scope of practice. And so with that, although I cannot speak to whether or not the educational require or educational qualifications for a CSW actually qualifies them to provide diagnosis and psychotherapy. Again, I just want to offer some information about current standards and best practices that might be helpful. Ms. Somerville had referenced a Model Social Work Practice Act. I'm not sure if she was referring to the ASWB's Model Social Work Practice Act, but it looked like there might have been some scope of practice language that was taken from our Model Practice Act. But we have a Model Practice Act that was developed in 1997. It was adopted by our membership at that time. It continues to be reviewed annually. It's updated to stay current with best practices. All of the changes are adopted by a formal vote of our ASWB membership. So that means all of our state agencies are agreeing with any changes that are made to that document. And I just want to say that the changes recommended by the board are consistent with best practices and social work regulation as presented in the social and the model law, we call it. So the board and the committee is in really good standing with regard to consistency and best practices. The provision of diagnosis and psychotherapy is considered advanced practice. It's restricted to licensed clinical social workers or master social workers practicing under clinical supervision. Bachelor social workers are strictly to engage in generalist practice. And again, I provided more detail in my written comments. I also want to say that the changes that the board put forth are consistent with national standards for social work licensure and the regulation of social work practice. And one of the things that we do to provide support to our members is we review regulation and statutes. And I did that in preparation for this meeting, and you have a 25-page report that you are welcome to look into at your leisure. And I performed a review of all state social work statutes and regulations, and in particular, scope of practice definitions, to really sort of explore this issue of diagnosis and psychotherapy services and how other states are handling it. And I found that it's almost exclusively limited to clinical scope of practice or master's social workers practicing under clinical supervision. So to reiterate the best practices that we found in the model law, we're also seeing throughout the US, in every state of the US, with the exception of one. And again, I provided you that report as part of my written materials, so I won't go into more details there. Then I'll also say that there are universal standards for social work licensure with regard to clinical master's and bachelor social workers. And that is that bachelor social workers have a BSW and they take the bachelor's exam. Master's social workers have an MSW and they take the master's exam. Clinical social workers have an MSW. They have 2 years of supervised practice experience. And then in addition, of course, they take the clinical exam. And so when we're looking at what the national standard is and best practices, the individuals that are performing diagnosis and psychotherapy within the social work profession are qualified through their degree of a master's in social work and through that period of training, that 2 years of supervision that they receive. So again, just national standards are really supporting the board's changes to the CSW regulations. And I would say that these aren't really changes, they're more of clarifications because the statute really is clear, as I've said. And I just want to make one final comment that I think is perhaps maybe the most important comment, and that is with respect to the exam that's used for certified social workers. And as I mentioned, that's the bachelor's exam. And the purpose of doing these licensing exams is to really test a social worker's knowledge to ensure that they have the minimum competence and can demonstrate that competence prior to entering practice. And I know that the board had expressed some concerns that it's possible CSWs were working outside of their scope of practice. That's problematic when we look at what they're actually being tested for, the knowledge, skills, and abilities, the KSAs that we're testing for for them to begin bachelor's practice. The bachelor's exam does not test for minimum competence to provide a mental health diagnosis and psychotherapy services. That's addressed in the clinical exam. Now, the KSAs form the content outlines for the exam, and there's a really comprehensive process that we go through every 7 years to ensure that the content of each exam is relevant to current professional practice. And I have, again, provided a lot of information about that practice analysis and how that really kind of takes a snapshot of what does current professional practice look like for social workers? How do we identify those content areas? And how do we make sure that we're testing on those content areas so the individuals entering practice are up to today's standards and can practice ethically, competently, and safely? And I would just say that the differences between the content outline for the clinical exam and the content outline for the bachelor's exam are significantly different in that we are not testing for knowledge with regard to diagnosis and psychotherapy. And so with regard to any changes or amendments or work that the committee or the board does moving forward, I think it's important for you to kind of keep those best practices and national standards in mind in terms of any potential changes you might make to the CSW scope of practice. And so I'll just conclude my comments there. I'm happy to answer any questions or come back at another time. Thank you very much.
Thank you, Ms. Sanner. Questions for Ms. Sanner. Representative Sweeney.
Thank you, Madam Chairman. So am I correct that your organization supplies the test and then you are accrediting basically our board and those rules, those tests on accreditation? Is that correct?
Ms. Sanner.
Madam Chair, Representative Sweeney. No, I'm not sure that I would characterize it that way. We do not accredit your board. The relationship that we have with your board is that of I wouldn't want to say contractual, but we essentially develop and administer the licensing exams on behalf of the social work licensing authorities in the US and Canada. It just so happens that every state uses our exam. We provide information about social work regulation, and as an organization, we have developed best practice standards that we provide as an informational resource through our Model Practice Act. So we do not, in fact, accredit the board, but we do have a relationship where we try to provide information and support where needed. And then, our main function and focus is the exam.
More questions for Ms. Sanner. Representative Stivar. You're muted. Oh, there you go.
Yes, ma'am. The question I have is, and you guys use the NASW, the National Association of Social Workers Code of Ethics, when you're going through this stuff, correct?
Ms. Sanner.
Madam Chair, Representative Stivar, that would not be appropriate. Those are sort of two different things. What we do is we develop a comprehensive survey of the social work profession, and we receive tens of thousands of responses. So this practice analysis helps inform the content outlines of the examinations we use for individuals newly entering practice to ensure that they are competent. And so in terms of any professional standards or code of ethics, that would be the responsibility of the state. You would address those in your state regulations. Because really, what one area is for practice, right? So that would be the NASW piece. And we're sort of the other area, which is really regulatory's responsibility to ensure that the public is protected and that individuals can demonstrate that they're minimally competent to practice.
Okay, more questions for Ms. Sanner? I don't see any. Thank you very much.
All right, thank you.
Okay, next on our list, and I apologize for sort of hustling people along, but it's kind of a long list. And I'll just say that. Kristen Alcala. Are you still there? Oh, there you are, Kristen.
I am.
Thank you. Trying to sneak off to lunch, I know.
No, thank you very much, Madam Chair. I am the LCSW currently on the State Licensing Board, and I simply wanted to be here if there were questions for me.
Okay. Are there questions for Ms. Alcala? Representative Sweeney.
So why are we making these changes now?
Ms. Alcala.
After it sounds to me like 20 plus years we've been doing business quite well. So that's my question. Why now?
Ms. Alcala.
Thank you, Madam Chair, Representative Sweeney. We initiated this rule change following the board's order in a case several months back. The board's order explained that the rules were ambiguous and they were unclear to people to be able to prohibit psychotherapy or other practices that are inappropriate for a bachelor's level social worker. So we did this rule change in an attempt to seek some clarity and align with the national standards.
Okay. Other questions for Ms. Alcala? Representative Sweeney.
Follow up. So you've had one complaint in how many years?
Ms. Alcala.
Thank you, Madam Chair, Representative Sweeney. I could not give you a number of complaints. There's been significant concern. There's been one case.
Okay, very good. Thank you very much. Who knows, we may call upon you again. Tori Shepard. Up there you are.
Madam Chairman, and
like your background. You look like you're out in the snow.
It's white.
That's good, actually. It's go ahead.
So I'll keep it brief because I did have my 3-page report, so I won't share that. I would just hope that you could consider like a grandfather clause or possibly a grace period for the existing CSWs, because my concern would be what happens to the CSWs who are working in this position with clients, and then what also happens to the clients. And yeah, so it just seems rather sudden to just refer out our clients. So yeah, that's all I have. So thank you.
Questions for Ms. Shepard? Representative Sweeney.
Thank you, Madam Chairman. Where did you get your bachelor's degree? Was it through the University of Wyoming or another state?
Ms. Shepard.
So I graduated from the University of Wyoming, and I'm currently working on my master's degree through University of Nevada, Reno. So.
And
Chairman Scott. Oh, I'm sorry. Go ahead, Representative Sweeney.
So, to my point, I know some people in the bachelor's level who are very nervous at this action, and who, my understanding, there's only 11 possible slots after you've left the university bachelor's to go to the master's. And then according to the advanced standards, there's really only one slot. So we're forcing our students out of state I guess Idaho's got a great program also that can be done online versus the master's program at UW. Would you say that that's correct, that our own state can't provide the training?
Ms. Shepherd?
Yeah, so there is a limited number of seats for the masters. And there are CSWs at my agency who are in the same position as me and who are very worried. And ultimately, the University of Wyoming is local, and it also, the price differential is without comparison. And so I have coworkers who are looking at, do I continue my education out of state and pay that extra money and have to possibly travel like Walla Walla, or do I just give up and seek employment elsewhere? So it's a difficult position to be in, I guess.
So I guess I'm not sure, Representative Sweeney, that the parallel is exactly the same, because, for example, if I were a nurse, I could work to the maximum scope of being a nurse. And if I wanted to be an orthopedic surgeon, yes, I would have to go out of state to become an MD. But to say that because I can't be trained as an orthopedic surgeon in the state of Wyoming, that that's somehow a fault of the nursing program. I mean, I think I just want to be clear that those are different things. We're not necessarily saying that everyone who wants to work their way through every level of a profession has to be trained here. But so, Ms. Shepherd, I did have a question. So as far as, sounds like the specific issues are really the diagnosis and psychotherapy. So my assumption would be that if you have lots of clients, I mean, and I apologize, I don't really know, obviously I don't know exactly what you're doing, but if you're seeing, clients every day, say 8 clients a day or something like that, and you're working with them on family relationships, or I don't know what all of the problems that the people that you might be specifically working with, but if there's an issue where say a new patient comes in, are you saying that there is no person in your agency who's practicing at a licensed level who would not be able to visit the patient one time and provide a diagnosis and then send them to, I don't really see, it's not like you would have to send all your patients away. I mean, a diagnosis would only happen presumably, one time, and then you'll see them for the remaining 52 weeks of the year or something, right? So I guess flesh out for me how you're feeling that somehow all the patients would have to go somewhere else.
So the way I understood the rule change, it would significantly restrict the clinical work that I'm doing. But hearing you say that it would be possible because I do work under clinical supervision of a LCSW. And so hearing you say that it would be possible for them to possibly do the intake and make that diagnosis, and then for me to continue working with them, that's honestly a relief, because I didn't understand it that way.
Well, and let me just say, look, I'm not on the board, so I don't want you to take what I hypothesized as the answer. I'm just interpreting it the way what I was thinking. So just be clear on that. But any more questions for Ms. Shepherd? Oh, Senator Scott.
Yes, Madam Chairman, for Ms. Shepherd, am I right in thinking that for yourself personally and for some of your coworkers, you think the current set of regulations, if enforced, would cost you your job? Is that right?
Yes, Senator Scott, that's the way I understood the rules. It would potentially, because there wouldn't be enough BSW level tasks, essentially. And so I guess that was a concern.
Senator Scott.
Yes, Madam Chairman, let me say, I think that the compromise that Ms. Somerville is trying to work out, that the language that we saw earlier is probably leading in the direction of saying that you can continue doing what you're doing now, but you're probably not going to be able to make a diagnosis. Somebody else is going to have to do that, as Madam Chairman described. And let me say just that it is my hope that one way or another we'll get that achieved. We'll see whether it might require one of us to bring a personal bill, and I might be willing to do that if necessary. I'm hoping that everybody can agree on some specific language and it winds up in the bill we've already approved. So I really want to reassure you that I think we're going to try to do something about this, because I think there's an unintended consequence of the rules they did.
Well, thank you, Senator Scott, and thank you,
Very
Chairman.
good. Okay, let's go on Laura Groshong. Oh, you're muted, so there you go.
Thank you,
Welcome.
Madam Chair. Thank you very much. Thank you, members of the committee. My name is Laura Groshong, for the record. I'm an LICSW in Washington State, and I'm also the Director of Policy and Practice for the Clinical Social Work Association, national organization representing the 250,000 clinical social workers in the country, of which about 1,100 are in Wyoming. I want to support the comments of Ms. Sanders, and I think it's important to put the issue you're looking at in context. As Ms. Sanders noted, there are 4 tests to prove your competency in certain kinds of social work. Social work is a huge profession. There are about 750,000 in all of the areas that we work in. But clinical social work is a specific subset. And I know how difficult it is once the scope of practice gets blurred in the other subsets. And that appears to be what has happened in Wyoming. And I do apologize for being kind of late to the game here, because I wasn't aware of what was happening. But I've worked in about 30 states on these kinds of issues. And even if you have just one case, I assure you there will be more. This is a very important part of how clinical social workers maintain their credibility as independent providers. And that is why 48 other states, and including Wyoming, differentiate between the scope of practice for clinical social workers who have 4 more years of training, specifically in doing mental health treatment, which bachelor level people do not. And I'm not at all being critical of what the work they do. I think it is very important. It's not clinical social work. So I encourage you to think about the difference between these 2 different scopes of practice. And I want to refer you to a situation in Washington State that happened about 10 years ago, where this very thing happened. There was a category called registered counselors, and there was a huge problem because many people were doing clinical practice that were not qualified to do so. And I'd be happy to give you details on that if you're interested. It's Representative Bouchard, addiction treatment is part of the scope of practice of clinical social workers. I'll be glad to provide you with details on that if you're interested, but that is part of our scope of practice. It's in the DSM-5. That's what we use as the base for our practice. And we're qualified sometimes with endorsements in addictions, but mainly it's part of our scope of practice. Be happy to answer any other questions.
Thank you very much. Questions for Ms. Groshong? Representative Sweeney.
Thank you, Madam Chairman. My question is, so you've got a bachelor's degree, but you've been practicing in doing in practice for, let's say, 10, 20 years. So all of those, because I truly believe this has been going on probably 20 years. So 40 hours a week, 2,080 times 20, 40,000 hours of experience. But I've only got a bachelor's. In your opinion, does any of that life experience count for anything in your opinion, and only because you don't have a master's degree?
Ms. Groshong.
Thank you, Madam Chair. Well, Representative Sweeney, I would refer to the chair's comments about if you have education, and I'd take it further. If you're a nurse's assistant, you're not going to be able to do the work of a registered nurse. And it's similar in social work practice. You want people who are doing work, especially sensitive work that involves mental health treatment, to be able to diagnose and conduct psychotherapy. Bachelor level people, social workers, have not had that training. They just haven't. Some people have gone out and been able to find it or start it. And social work, clinical social work is a relatively young profession. So people were doing things that have become more codified over the last 20 years, I'd say. And you're right, there probably are people out there who started doing clinical social work because they could. And there is definitely a need for more mental health providers, but that's a separate issue. I believe it's in the best interest of the citizens of Wyoming to have people who are properly trained to do clinical social work. And if we're talking about diagnosis and psychotherapy, we're talking about clinical social work. So that's what I would say. I think this is part of the evolution of this profession. And it is in the best interest of everyone to differentiate between what clinical social workers do and bachelor level social workers do.
Senator Bouchard.
I have a question about addiction specifically because it just kind of triggers my thought process here. Do all social workers get training to do addiction services, or are there some that get special training and some that don't? I mean, because we've had these arguments on the other side of the wall where we have addictions professionals and that's all they do and they get training for that. So I just want some clarity there.
Ms. Groshong.
Representative Bouchard, you're addressing something that is a national problem. There are silos between addiction and mental health treatment. And my understanding is that there are far more co-occurring disorders than there are independent problems with addiction or mental health. That means people have both of them. So you want to have, ideally, people who can treat both conditions, however they manifest. And again, this is an area of evolution. I think treatment of addiction as a specific methods for treatment of addiction have been developing over the last 10 or 15 years. And clinical social workers who are working with that population have educated themselves and gotten additional training to be able to adequately treat those people in addition to handling their mental health problems. So you're right. There is some different, there are different treatment methods, but in terms of diagnosing those conditions, clinical social workers are competent to do so.
Okay. Any more questions for Ms. Groshong? Very good. And keeping in mind, thank you, Ms. Groshong, very much. I'm again kind of going down the list somewhat rapidly because we're not considering the bill at this time, but just having had a lot of people sacrifice many hours of their day, didn't want them to not be able to express themselves. And plus, this may give some scope to what we're thinking of as far as session. Ms. Foland, welcome back. Oh, where'd she go? Oh, there you are. You're getting used to us.
Thank you, Madam Chair. I am getting used to you guys, and I love it. Thank you, Mr. Chair, Madam Chair, for this opportunity to speak. There has been a great deal of conversation over the last couple of years, actually, on this specific topic of bachelor's degrees versus master's degrees and even PhDs. And I will go on the record to say just because we have advanced degrees doesn't make us any smarter. I have a lot of colleagues who have bachelor's level degrees that I work with here in Rollins who are absolutely superb. However, as both the ASW representative and our previous speaker have identified, there is a difference in clinical social work. And many states are even differentiating a master's level social worker license versus a licensed clinical social worker license. And our bachelor's folks are great. I don't think a grandfather clause would be a bad idea to consider. The language, I think, could be tweaked just a bit, and I'm happy to work with Andy and her group to identify some other considerations for the potential bill. But I think we do stand to benefit our communities by looking at the quality of services that can be provided and allow that career path, career ladder, as we have discussed in the addictions professions, to look at the same type of opportunity. We are hamstrung by the educational opportunities provided to us within Wyoming. And it is a topic that we're going to have conversations with UW and others. But I encourage the committee, and I thank you all for taking this on, encourage the committee to kind of look a little bit more broad, where we are looking at losing monies to the services that we do provide. And we do need those individuals who can demonstrate competency to be able to provide those services. Thank you, and I stand for any questions.
Questions for Ms. Boland. Chairman Scott.
Madam Chairman, question for Ms. Boland. I'm hopeful that we'll be able to get a compromise that everybody can live with. But in the event we do not, would it be a feasible thing to remove the licensure of these bachelor's level people from the board where there's a conflict of interest in terms of more senior, and say turn the Department of Health or some other organization like that? Would that be a feasible thing if we can't get something worked out?
Ms. Boland.
Thank you, Madam Chair, Mr. Co-Chair, Senator Scott. I do believe that the conversation should be opened up to look at those opportunities. What are our alternatives, and identify, does this make sense? My concern is those unintended consequences, as you identified earlier. It is perhaps something that could be looked at very seriously, and I think we could come up with a compromise in that area. And thank you.
More questions for Ms. Foland? I do have one, just slightly sideways, but while we're extracting useful information, you brought up the training. Do you happen to know, is there a master's level social work program available through WICHE that would be online?
Madam Chair, at the moment off the top of my head, I'm not aware of one, but I do know that there have been discussions of incorporating one into it. I just don't know where we stand at the moment with that.
Let's see, is Senator Baldwin still here? Senator Baldwin, wake up. Senator Baldwin and I are on the WICHE board. I mean, that might be something that at least I'll look. I didn't actually go to the Sacramento Zoom meeting this year, but it does sound a little bit like some sort of online MSW program through WICHE could be extremely useful. I'm marking it down.
Thank you, Madam Chairman. We actually have a meeting next week, a commission meeting, so I will bring that up.
Oh, thank you, Senator Baldwin. It sounds like that would be very useful. Okay, I think that looked to be all the questions for Ms. Foland. Ms. Schmidt-Palazzo, welcome back. You've been waiting very patiently.
Thank you, Chairman Wilson, senators and representatives. I think one of the problems is that the licensing board's attempting to fix a problem that doesn't exist. And it's one of those where it's a theoretical problem. There are national standards. I have been to dozens of national meetings for ASUW in my tenure as the chairperson. I've been to NASW national meetings. So I understand those issues, but we are Wyoming, and Wyoming, sometimes we think we're different and we're really not, but in some situations we are. And I want to reiterate that we are a HPSA area, that professional shortage area for mental health and substance abuse. The other thing is that we have to broaden this conversation out to those CAPS and CMHWs. If you are not able to do counseling, now psychotherapy, if you want to throw that off and say only master's level people can do psychotherapy, fine. There's somewhat of a difference probably between psychotherapy and counseling. But counseling has been done by these CSWs for 20 years. And for 10 years, it was actually in the rules and regs. So when we're saying that the board is saying that the people have done this inappropriately, they were actually doing it under the rules and regs of the licensing board that said that they could do clinical social work, which included diagnosis and counseling. So there was not anything inappropriate. So to think that all of a sudden today, people who have done this for 20 years or 10 years or possibly a few years, like the one who just was on Tory, to think that they were doing something inappropriate is not fair, because they were doing it based on the rules and regs of the state of Wyoming under this law. I do have a tremendous concern that there is no grandfathering provision, that if this is going to go this direction, there is no ability to grandfather. And if we look back to the 1990s, we had a whole bunch of CMHWs who were employed at the time. Many of them did not have a bachelor's degree. They were people who were working in the field for 10, 15, 20, 30 years. They didn't have a degree. We grandfathered all of them in. There's still, I believe, there are 8 of them who continue to be on the roster. There are 100 CSWs on that roster, just like Tory today. Some of those work in my agency, and they're doing tremendous work. It is not independent. Somebody had mentioned that they should not be allowed to do independent work. Nobody is suggesting that any of these bachelor's people are doing independent work. That is not up for debate. in the rules and regs, it directly says they have to work under a qualified clinical supervisor. I meet at least an hour, hour and a half with my people every single week. There is no way that they're not doing something under supervision. And then I review all of their other work throughout the day and week. Medicaid and insurances have been reimbursing for counseling, assessments, everything for decades for these people. And then to say all of a sudden their scope of practice changes. And I will tell you, if their scope of practice changes to the ability that they can't do counseling and Medicaid and insurance does not pay for them, then people like Tori will have to lose their job. People in my agency who are CSWs will have to lose their job because there is no reason that we would have them employed in those positions. Possibly another position would be available. I'm not saying that, but there's no reason to have a CSW if you can't actually do something to get reimbursed to do that. If diagnostic is such an issue, then add a test to demonstrate competency. There's a way to demonstrate that you've got competency. Either these ones who have been working for a long time or new people, you can demonstrate competency. And I get that this may not fit with all of the national standards, but I will tell you that the work that my people do in my agency, it is way comparable. I mean, I've traveled the whole country and looking at programs and doing all sorts of different things. People who are working in my agency at this level, it is comparable to people all across the country who are at the master's level or whatever level they happen to be at. We are not dummying down treatment by these people. So I want to just urge you to come up with some real solutions for Wyoming. And I get that there's some national standards. I support national standards. I support these organizations. But I also feel like we've got 100 people out there that are going to be dramatically affected if we don't do something to help them. Thank you.
Okay, questions for Ms. Schmidt-Palazzo? Senator Bouchard.
Thank you, Madam Chairman. I have a question. Have you spoke to the board directly, and was there any kind of reply, or what was the communication like between both you and the board?
Ms. Schmidt-Palazzo.
Thank you, Chairman Wilson. Senator Bouchard, I was unable to testify during their hearing because I actually was testifying before the SLIB committee to try and get some funding. So that took precedence. I have had email communication with Greg Searles, and he's been very great at getting me the information I've requested.
More questions for Ms. Schmidt-Palazzo? Representative Sweeney.
Thank you, Madam Chairman. I just wanted to clarify, you said something, you were chairman of this very mental health licensing board, and how many years ago was that?
Thank you, Chairman Wilson. Representative Sweeney, I was on the licensing board from 1998 to the year 2013. I believe I was the chair the last 4 years-ish, maybe 5.
Representative Sweeney.
Just a quick follow-up, but thank you, Madam Chairman. So in all that time that you were on the board, thank you for your service. And did you ever think you were doing anything inappropriate licensing, even, in this particular scope of practice?
Ms. Schmidt-Palazzo.
And thank you, Chairman Wilson. Representative Sweeney, the interesting thing was that before I was on the licensing board, I was on NASW's Wyoming chapter board, and I believe I was the vice chair when we worked with the legislature to get the CSW's part of the law passed. And as NASW, we were very, very supportive of social workers doing this kind of work because we have such a dearth of professionals in Wyoming. So no, we did not. I never thought that there was anything inappropriate. I will tell you that I reviewed every single complaint the other day that has been, that has had disciplinary action with the licensing board, and only one complaint actually had disciplinary action for a CSW. I happened to be the investigator on that situation. It was a Medicaid fraud for somebody doing the DD waiver stuff. She didn't even need to be a CSW. She just, anybody could have done that work. And she ended up with disciplinary action. And at the same time, there's been 58 disciplinary actions against master's level people. So to think that that the CSWs are the risk to do something difficult, I don't think that the data really points to that. But I think one of the changes, one of the differences is that people who are at that CAP level and the CSW level have to be under that intense supervision every single week. And so there is quite a difference of the practice that they end up having.
Okay, thank you. Folks, let's remember, we're not carrying a bill at this time, so we're just getting kind of background information, and hopefully we won't have to hear all the background again in January. Not that it's not wonderful. Any more questions for Ms. Schmidt-Posado? Okay, super. Thank you very much. Mr. Searles, I'm skipping over you for the moment, just because so you can clean up if you want to. Kelly Heenan. Are you there still?
I believe that Ms. Heenan had to leave due to another obligation.
Okay. Is Mr. Searles, have you got anything to contribute? Well, that was interesting. You sort of popped up in front of a brick wall. How'd you do that?
It's a virtual background, ma'am.
Yeah, it kind of came up first. You look sort of like the Cheshire Cat. Okay, go ahead, Mr. Searles. Have you got anything to add to the conversation?
Madam Chair, the only thing I would add is the part of the discussion is over the word counseling. In counseling, as Andy Somerville pointed out in her testimony, excuse me, once again, board members, committee members, I'm Greg Searles, the executive director for the Mental Health Professions Licensing Board. Part of the discussion today has been over that word counseling, and counseling is already defined in statute to include psychotherapy. And as Ms. Sanner and Ms. Grishong have testified today, psychotherapy is not appropriate for the bachelor's level. So that's where the concern with counseling is. Social work has its own definition of counseling, which is different than professional counseling and has led to some of these confusions. And we will continue to work with Andy and other members of that group to try to get rid of that confusion over the word counseling and how it varies between the different professions that are all handled by this board.
Okay, so what I understand, just to rephrase, what I understand you from, circling back to Ms. Somerville's presentation, is that you folks anticipate putting a specific definition for social work or for certified social work in some way such that it would delete psychotherapy, but in essence maintain all the other counseling capabilities that they are performing. Is that what I understood?
I believe that's the intent of Andy's proposed language, Madam Chair, and the board will gladly work on that.
That does sound like that would solve 80% of the problem. Any questions for Mr. Searles? Representative Sweeney.
Thank you, Madam Chairman. In testimony, if you were online, did the board consider anything to do with grandfathering, to grandfather in the people that are currently practicing?
Mr. Searles.
Madam Chair, Representative Sweeney, when it comes to psychotherapy and diagnosis, no, the board has not considered grandfathering them in because they don't believe that they should have been doing those services under their education and testing for competency. The counseling as defined by social work, the board believes that those individuals can continue to do.
Very good. More questions for Mr. Searles? Okay, thank you. Folks, I think that wraps up the certified. Yes.
We do have one more individual who is available for public comment. She's the last addition via email.
Okay, put her in.
To be here.
Can you hear me?
We can hear you.
Okay,
Welcome.
thank you.
So just introduce yourself.
I'm Cecilia Mikesell. I'm a certified social worker. I'm sorry, I'm kind of juggling with a doctor appointment right now. But I'd like to just read you a statement I wrote in case I had to leave.
Okay.
I've been seeing clients clinically for many years. When I graduated from college, I did not realize that this line of work would be what I would be doing in the social work profession. Had I known, I would have furthered my education at that point. I do not deny the value of furthering it now and plan to do so as soon as I'm able, while prioritizing raising my family first. I have always been and continue to be under the supervision of a licensed clinical social worker. I have been trained extensively in clinical work, including psychotherapy and diagnosing, as per my required continuing education credits, as well as many years of experience. I have about a year less of training than in LCSW because it would have taken me a year to get my master's, and I've been under clinical supervision doing the same kind of therapy for quite some time. There are limitations to what a certified social worker can do, understandably so. I would just ask the board to consider allowing time for those of us who have full client loads to continue working clinically until we can get back to school. There are some limitations financially, especially. I know one of the ladies said she's attending a school at Reno, which is drastically higher tuition than the University of Wyoming. And I can see where this rule change might be being considered in order that the best mental health services are offered to our clients, which should certainly be of the utmost importance. I would offer, however, that taking us away from our clients with sometimes years of therapeutic relationships in play in such rural communities is not in line with what is best for our community's mental health. If there are issues of unethical practice triggering this change, those will remain the same after this is done, no matter the level of education of providers. Those of us who are doing ethical, preventive, and vital work with our clients will continue regardless. The difference lies within character, not education. I just wonder if there's a way we can ease into this rule change rather than abruptly removing us from our incomes, clients' welfare, and agencies. As far as grandfathering, I'm really curious about that as giving us time to get our masters. I also take note of what one of the ladies was mentioning, that there's another way to kind of measure our competence in what we're doing. Could we grandfather in such a way as to take these tests that we normally would, with the intent that, yes, you'll be getting to school and Wyoming is getting to where, you know, we only want LCSWs in this position, but something that, even if they're not allowing any new certified social workers to be in our realm, to so abruptly take us from our clients and our incomes and things. And certainly none of us are going to go rogue or shouldn't be performing tasks that we shouldn't be without supervision. So that's kind of what I had to say.
Great, thank you. Questions for Ms. Mikesell? Okay, thank you very much.
Thank
All right,
you.
folks, we assume that we will send out the various interested parties to continue working on this. It does sound to me like the counseling issue can be pretty well resolved. We may be able to get most of the way there to somewhat of a satisfactory place by session. And that would probably then be an amendment to the bill that we've already drafted. Okay, so a mere hour and 23 minutes late, we will take our lunch break. Let's aim come back at 2:15, because I know LSO sometimes likes to leave the building and eat something other than chips and Diet Coke or Diet Pepsi. When we come back at 2:15, we will discuss LSO 225, the community behavioral health priority populations. Just so people know, on the in case you have something else to do, item number 7, consideration of draft legislation on the state health reinsurance program. The bill is still posted on there because I didn't want to take things on and off and on and off. But after meeting with the insurance department, I think we will hear from them that we are not ready to bring that bill back because the background of that bill required an appropriation and some consultant actuary type work that we would basically have to redo because those are several years old data. So if a person who wanted to communicate on that is called away for the afternoon, I don't think you should worry that you will miss your opportunity, because unless something really radical happens, I think we are going to say, okay, thanks for the information, but we're not going to actually move that bill to be a 21 session bill. That's just at least my thought of where we're at the moment. So no further information. Representative Sweeney.
Madam Chairman, on the subject of the certified social worker, would it be appropriate for the chairman to write a letter to the governor asking him to wait on signing this so that we have appropriate time to work on a solution?
Well, I don't really have any firm opinions on that. Co-Chairman Scott?
Madam Chairman, I think that might be a good idea. I do think there's a good chance we're going to get a compromise. And I would certainly be willing to write such a letter. Madam Chairman, how do you feel about it?
I think I would be willing to ask him to put it off to the last week under the assumption that we could come up with some compromise amendment language. I do think that if we do not come up with amendment language, that they need to really go forward. I mean, I don't think we can just say, you know, a 6 months worth of regulatory work is just changed just because maybe we'll think of something better. You know, I mean, I don't think, but I think certainly I'd be willing to say, we're working on it. If it's not due until December 31st or some such date, you know, ask them to give us another month. That I think that's fine.
Madam Chairman, given that we don't have another meeting, I really think they need to put it off till after session.
Well, if nothing happens though, then they'll have to start all over. Representative Barlow.
Thank you, Madam Chairman. Maybe just a reminder for everybody where it actually all is in the process, a technical process, so that we can be clear about how that letter would impact. Is it before the governor now, waiting to be signed? Just remind me and everybody. Thank you.
Mr. Brody probably knows, but yes, it's gone through the whole rule writing process. I believe it's gone through Management Council and the AG and is awaiting signature. Do you know, Mr. Brody? Or maybe Mr. Searles knows if he hasn't gone to lunch.
Madam Chairman, I can comment that LSO has conducted its rule review and provided that to Management Council. Whether or not Management Council has acted upon it, I do not know.
Representative Barlow, perhaps you know that.
Madam Chairman, to that point, that's why I wanted to verify is where it was so that we would know within the process. Thank you. I will check with that and I'll have an answer by the time we return from our break.
Good. Let's finalize that after lunch. Okay. 2:15 and we'll be back for item number 6.
Madam Chairman?
Yes, Mr. Brody.
Just one thing of note, Staff sent you an email as chairman of the committee in regard to the availability of Representative Larson for item number 6. You received that email?
I don't know. Let me look. Hang on.
Long and short of it is he has a professional obligation beginning at 3 p.m. So his time is limited.
Well, we will shove him right in at 2:15.
Ma'am, also would also like to know anybody who is watching this stream, there will be a new PM stream this afternoon that you'll look for on the YouTube page. For those Zoom users, you'll stay within the same meeting. It's just for those who are watching on YouTube.
Okay, committee, remember to turn off your mic and your picture, and we'll be back at 2:15 promptly so we can plunge into the draft bill.
Madam Chairman,